Right, let's go. Okay. Well, good morning, everybody. Good morning, good morning. Good morning, and welcome to Thurston. What a fantastic location, isn't it? Lovely to see you all, and welcome to the September Suffolk North East Essex ICB meeting. It seems a long time since we met in July. I don't know whether that's just me or whether we all feel that way, but lovely to see you all. Just a reminder, we are live streaming, so we're meeting in public. Welcome also to members of the public in the audience. Nice to see you. I think a couple of intros. Frankie, I think this is your first board meeting as our medical director, isn't it? So do you want to say hello and introduce yourself?
Thank you, Chair. I'm Dr. Frankie Swords. I'm a consultant physician 1 day a week, and the rest of the week I'm the interim medical director of Suffolk and North East Essex, as well as the executive medical director of Norfolk. Delighted to be here.
Okay, thank you very much. And I think around the table, I'll come to you in a minute, Louise, when I do apologies, but I think we've got Liz and Gareth, you're contributing to papers. Anybody else who I should have said hello to? I think we're done, aren't we? So in which case, then let's go on to apologies. So Tom, just check me out here. I've got apologies from Fanwell Wittenbury, from Caroline Donovan, and Kath is here for Caroline, from Gareth Everton, and Louise, you're here for Gareth, so welcome. And then apologies also from Nick Hume, Moira McGrath, Laura Taylor-Green, and Kirsten Alderson. Any others?
Peter Whiteman.
Oh, and Peter as well. Okay, thank you. Okay, Peter Whiteman. On that basis, Tom, are we quorate?
We are.
We are. Great. Good news. Let's then move on to questions from the public, which, to get, if you like, a substantive answer, must be relevant to the agenda. We do have 4 from Mr. Dooley, who's not with us yet, and 1 from Mr. Benson, although that is Mr. Benson's is in 7 parts. What I propose to do, though, is take them at the end of, in the item at the end of the agenda, on block. Tom, do we have any other questions from members of the public at the moment? None? Okay. Declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item, other than those of which we're aware, of course? All noted. Lovely, thank you. Minutes of the previous meeting, 15th of July. There's a couple of typos. Can I come to you for those, Tom? Do you want to grab that mic? Yeah.
Yep. So I've been notified of some typos, so thank you very much for those. Those will be corrected in the final one. The substantive correction I want to make the board aware of is in paragraph 8.3, the take-up of the NHS app should be 75%. I've undersold us somewhat in the minutes and put 5%. So just need to correct that.
So 5 to 75, and then minor typos in the usual sense. Any other issues in the draft minutes that you've received? Otherwise, subject to those comments, are we happy to approve the minutes of as a true and accurate record of the 15th of July? All done. Great. Matters arising and review of actions. Now, as far as I could tell, all bar 1 were all complete or on the agenda or in the future plan. The one I'll come to, if I could come to you, Elaine, because I know you're going to give us the next steps on that dental delivery plan action that's in the list.
Yes, so we discussed that, Lisa, myself and Frankie will take that to the next Quality Committee in October, which is the 9th of October.
So Quality Committee in October for that item. Any other issues on the matters arising or actions? Everybody content, therefore, that that is a true and accurate record? And are there any actions that you thought should have been captured which weren't in the schedule? So also, no, non-raised, so also a complete record. Okay, great, thank you very much. In which case, item 6, Ed, can I come to you for the CEO's update, please?
Yeah, thank you, Chair. So you've got in your papers the annual oversight letter for the ICB for 24-25. For information, can digest that and read that yourself. We won't be having a official rating, I think, this year because of the changes that ICB is going through. However, our providers have received their first ratings under the new national oversight framework. There's a lot of publicity and interest in that. I think it was last week or the week before. So I think those ratings will be refreshed every quarter, and I know that all of our providers welcome the accountability and are keen to improve on their positions. So we'll keep a close eye on that and support them to do so. In terms of the transition arrangements, so it's been confirmed that the Norfolk and Suffolk ICB will go live on the 1st of April 2026, and in a similar arrangements for the Essex ICB. It's no longer going to be called the Greater Essex ICB, it's going to be called the Essex ICB. And we've completed our recruitment process for executive directors. I'll be communicating the outcome of that this afternoon in terms of the directors that have been offered roles, and obviously we'll be acknowledging the fantastic contribution that all directors have made, those that will be staying with us in the future and those that will be pursuing new opportunities too. In the staff briefing, I'll also be briefing the staff around the concept of a regional office of commissioning that will be established in each of the regions and hosted by an ICB, so I'll describe some of the plans around that. Moving on to other business, so patients in North East Essex will now, who are in need of specialist cardiac procedures, will benefit from a shorter travel time now. They'll be able to be treated at Ipswich for PCI, percutaneous coronary intervention, I think that's how you pronounce it, yeah, at the Specialist Heart Centre. So really, really good, and one of the benefits of bringing in Ipswich and Colchester together. There's a new ambulance hub that is due to open at Ipswich Hospital, which is a really fantastic facility. There's a similar facility at Bury that some of us have visited, and it's really fantastic for the staff and for the productivity of the service. We're really pleased to announce that we're the only ICB in the country to have full coverage in the Neighbourhoods Health Implementation Programme. So all 3 alliance areas are going to be neighbourhood pilot sites. So we welcome the scrutiny, don't we, Maddie and others, and the expectation around it. But I think it's a great reflection on the work that's taken place over a long period of time and how it's matured. So very well done to everyone involved. Our winter vaccination campaign is underway. So we've got flu vaccination for pregnant people and children and other high-risk groups, for staff, and COVID vaccinations from the 1st of October for immunosuppressed people, older people and residents of care homes. And then finally, just to congratulate the University of Essex, who we've got a close relationship with. I think they've been ranked in the Guardian League table as the 12th best university in the country, so a huge leap forward for them, and really proud of that achievement. Thank you.
Thank you, Ed. Very, very good. And thank you to everybody also. I know in the pack for Ed's paper, there's a letter that's addressed to me about performance and how well we've done, if you like. But actually, although it's addressed to me, it's addressed to you all and to all our team members as well. So thanks for everything you've done. Any questions for Ed, or indeed any other relevant team member, on the CEO's update? Otherwise, Elaine, yeah.
Well, actually, it was about the letter from Claire. So, if is that appropriate? I asked that, given it was put in. So, first of all, I thought it was really good to see so many positive things called out in reflection of the work that's been done by the team. I thought that was great to see. I did want to, though, pick up on sort of looking ahead to what we continue to need to do to ensure we do have the good performance for the community we serve. Because one of the areas you picked up as a development area and to see improvement was particularly to make sure that we stay focused on the delivery of the implementation from the sustainability review recommendations. Now, I believe we should be covering that in the next board meeting. So the ask really today is just really to make sure that we have some really good evidence that we're making progress on that. So that would be the ask, that when we cover that at the next meeting, that we're really focused on it to make sure that we're getting the implementation we expected and the progress we expected.
No, thank you, Elaine. That was very, very well described, very nicely put. So for the next meeting, do you want to comment on that now, Ed?
Yeah, no, I really agree. My sense is that there's some excellent work developing around the care management service, and the concept actually across both of the ICBs is gaining a lot of traction. I'm less well sighted on the productivity work, so I think it would be good to have a look at both of those aspects.
Okay, thank you, Elaine. If there are no more questions, we are asked to note and endorse, so are we happy to? Noted and endorsed, lovely. In which case, item 7, the medium-term planning framework, etc. Richard, all yours.
Thank you, Chair. So colleagues will have seen that I think it's the earliest we've ever had, but we've had the National NHS Planning Framework came out earlier this month. So it's not the planning guidance, but it's a bit of a taster of what's to come. In terms of what we're being asked to do, you'll see within the document that it's in a number of different stages, and there are 3 products there's 4 actually, 4 elements that we're going to need to work through fairly rapidly. The first is an integrated needs assessment, so we've already got that well underway. So we're working really closely with our 2 public health teams, and that's really to have a baseline understanding of our population's needs now and in the future. The second element then is we need a ICB strategy. So that's the first time we've had an actual ICB strategy, we've had an ICS strategy. But as an organisation, going into the new arrangements, I should say, we will need a Norfolk and Suffolk ICB strategy and an Essex ICB strategy. So there's work starting on that across working with our Norfolk colleagues and also with our broader Essex colleagues on what that could look like. And then the third element, if that's not enough, is then a review of our joint forward plan. Again, it needs to be redone in the new arrangements, so we need effectively a 5-year plan for Norfolk and Suffolk and one for Essex. And then finally, the work that Maddie and Peter will be leading with our local government and other colleagues is a neighbourhood plan. So that's effectively our local places, so Ipswich and East and West Suffolk, working together to develop a Suffolk delivery plan for the local population. Where the timing of those is fairly tight, so we're being asked to have fairly strong drafts of those in November and ideally have them in complete form by January. As you can imagine, that's going to be incredibly challenging given that we're not effectively continuing in the current formation, as Ed said, but having to develop these rapidly into the new ICB arrangements. So we're going to have to think carefully around how we do that in the style that we usually try and do, which is engage, co-produce, but we've got limited time to do that in any depth. There is an understanding of that, I would say, nationally, and it is likely that for the first year of those documents, they are a work in progress rather than a polished final product, because for ICBs like ourselves, there's just not going to be the time that Susanna and I put in the first time round where we had 6 months or more to actually develop strategies and plans. So I would say that is a risk, but that is what we need to crack on with locally moving forward. We're expecting the fuller planning guidance to be out sometime in October. That will set out, and Howard may say more later on the finance item, our 3-year allocation. So there is an aim, which I think is great, that we get more certainty in terms of 3-year planning round. So that should give us, hopefully, more security looking forward about what we can do in terms of investment and other commissioning decisions that we will need to make. So Alex Royan and Chris Armitt and others as our deputies are effectively driving this locally now. We will have a small group that's coordinating this over the next 6 to 8 weeks, and we'll keep the board updated. I think by the time we meet again, we should have the full planning guidance, and we should be fairly far forward with all of those documents I've described. We are going to use the board development session, Will, coming up in October to go into this in a bit more depth, which we thought would be helpful.
Richard, thank you very much. So we're only asked to note today, but also note that we'll deal with it in depth at the board development session, which I think is the 22nd of October, isn't it? And then to board again in January, Richard, yeah?
Yeah, we'll see when we get the planning guidance out, it'll be clearer on the time frames.
Yeah.
So I would envisage January, but we'll probably bring an update anyway to the next board.
For the next board.
Yeah.
Oh, okay. Update to the next board, detail in January. And actually, as you say, a much better process this year, isn't it, timing-wise? Okay, so 2 hands raised so far. First of all, Dave, and then Elaine. Dave?
Yeah, thank you, Richard. Just really reading between the lines, I'm looking for reassurance that we are going to co-produce this neighbourhood health model with our frontline staff, so including general practice, but of course our voluntary social care sector, dentistry, community pharmacy, so that we actually get it right.
Yeah. To be fair, I think we do have longer, or Maddie and Peter are leading that, have longer on the neighbourhood plan. So the national timeframes for the ICB documents I've described is November, December, but for the neighbourhoods plan, that is effectively being led by local government with the ICBs. At the moment, that guidance is also being developed between the Department for Health and NHS England. I haven't seen early sight with my other hat on, and it's still a work in progress. But at the moment, they're looking at maybe March, April to have that in place. So I think we've got longer, about 6 months to do that.
Okay, just let me bring Ed in here. Oh, Frankie. No? Yeah? Oh.
I'll come in after.
You come in after Frankie. Oh, sorry, Elaine, I'll just hold you. Frankie, Ed, Elaine.
Thank you, Chair. Richard, you pointed out that we would prefer to spend more time co-producing and engaging, and I'm delighted to hear about the opportunity to do that with the neighbourhood plans. However, we're not starting from a blank piece of paper, so I think it's really vital, and we do intend to use the outputs of the previous work we have done to develop our joint forward plan and the clinical strategy in Norfolk and Waveney and the live well domains. You know, we're not starting from ground zero here.
Yeah, thanks, Frankie. Ed?
Yeah, it was possibly on a tangent, but Dave was telling me how successful the launch of the clinical professional leadership programme was recently, and we were just talking about if we could build on that programme for neighbourhoods, how effective that could be, not just in terms of delivery, but in terms of planning would be another benefit, wouldn't it? So we'll perhaps have a think about how that development programme across the 2 counties that we could put in place.
Okay, and I saw Richard nodding to that, so thank you for that. Elaine?
Thank you, Chair. So my question was about primary care, actually, because when I read through the paper, I couldn't quite understand where primary care fitted in. So just giving your response to David, I'm taking away that will be part of the neighbourhood plans, and that will be driven more from local government with slightly different timescale, though, is Frankie's saying built in. There's a lot of work already done there to build it in, so that helps.
Okay,
Thank you.
that's good. Answer to the question before you asked it, which is great. Maddie?
Thank you, and I was just going to build out from that with some assurances and some practical notes. So at the moment, as everybody knows, we're in the process of the recommissioning of community services, and there have already been 2 Suffolk workshops, so this is specific to Suffolk, with a very large range of partners taking place in that so far. There will be some further engagement with frontline staff through that process, and we're meeting this week with the community and partnerships in Stow Upland. So these conversations have already started, and I'm hoping that we can use some of the training and education time in February with the GP community to engage and start that process too. And the neighbourhood work is very, very inclusive. So I'm really positive that this will be a co-produced plan. Thank you.
Okay, thank you, Maddie. So, colleagues, today we're simply asked to note, But I think we're also noting that we have a process and time frame in hand that we're happy is not the right word, is it? Because we're never happy, but that we're pleased with the progress on. We've got some specific issues that board members have identified for focus, which we agree. Richard will lead a development session in a deep dive on the 22nd of October. We'll get an update to the next board, and then if we hit the current time frame, then it'll come back in more detail to the January board. Everybody content? Noted. Thank you very much. Winter plan. Richard, shall I stick with you to say a few words and then you're going to hand over to Liz? Is that the way we're going to do it?
Yeah, very quickly, because I won't steal Liz's thunder, who's doing an amazing job at pulling all this together and keeping us on the straight and narrow. So, as you'll see, colleagues, in the pack, we've got a cover paper and then the winter plan, which is effectively our all-year-round plan, but really focusing on that winter period where it gets even more challenging, although it feels like that most of the year round, to be honest. I think we've done a huge amount of work, again, to work with our partners on pulling this together. So thank you to colleagues around the table who can't be here today for the approach that they've taken working with us on getting this into place. But Liz will take us through more detail. Thanks, Liz.
Thanks, Richard. So the purpose of bringing the winter plan here today is to seek the board's approval to that plan, and specifically to the board assurance statement, which is in Annex B. I'll take the paper as read. I think it's important to understand that, as Richard's already sort of highlighted, that winter, of course, is an important period. We know that there is increased pressures on our system, but the board is already cited on the performance that we have across the system generally, not just across UEC, but obviously around mental health, elective care, etc. So that's the context in which this paper is set. And the quality impact assessment that's also included highlights some of those risks and the mitigations that we've also taken. There is absolutely heightened expectation both from the public and from the Secretary of State and the CEO of the NHS England around what should be expected this year and the standards of care, and specifically how we should be delivering that. And the winter plan goes into that in more detail. It's also important, I think a major difference this year is that we have been asked to live within the existing resources that we have. So this is the first year that we have not, as a system, identified additional funding we're either sort of tapping into now, or that we may be able to access should those pressures get increasingly heightened. So we will absolutely be living within our means, and that's what the plans articulate. We have absolutely taken a much more sort of strengthened approach to the development of that plan this year, absolutely in line with the national guidance that we've received. There's various references within the document to the different requests and emphasis that have been placed on that. We've tried as a system to really focus on, again, that co-production. So this year you'll see in our plans we've got responses from every aspect of our sort of provider network. So the alliances, and that has included engagement with primary care, VCFSE, local authorities, as well as with our sort of main urgent emergency care and elective care providers as well. We have tried to really focus in on additionality and also some of the difficult choices and consequences that we are going to need to take should the pressures arise. And that point around choices and consequences, the thresholds of decisions that we're going to need to make about shared risk appetite and decisions across system partners was something that came out of the system winter exercise that we did earlier this month. The assurance pillars, there's 7 of those, which are really around prevention and demand management, how we're maximising community provision, really focusing on our ambulance performance, particularly in terms of maintaining our C2 mean, ambulance to handover times, flow and capacity through all of our services. So yes, ESNEFT and West Suffolk are important, but so is NSFT, EPA and some of our other providers, such as integrated urgent care. Mental health, which we continue to see sort of pressures, particularly at Colchester General Hospital, discharge planning and workforce. The paper does include something that we've done for the first time this year, which was a system-wide winter exercise. It was really good to do that work with Norfolk and Waveney colleagues. So a common approach was taken across the two, but there were two separate exercises that were run. The main things that really came out of that for us was trying to get our sort of C3 structure, so our command, control and coordination, a little bit more focused on proactive rather than reactive response. I think it was helpful, again, that as a system we've recognised the importance of primary care and community services and a real desire and some additional work that we're going to do around trying to get better intelligence on the demand that's going on within those particular providers, and then some individual works that we know that we need to do. So, for example, refreshing our handover in 45 protocols in each of our 3 acute sites to make sure that we are managing that demand. So, just to conclude, the board is asked to approve the winter plan, noting that we are still waiting for the boards to have met within NSFT, Essex and West Suffolk, which is scheduled for this week. We have had confirmation that there's high confidence that those plans will be supported. That will then enable us to submit the board assurance framework, board assurance statement, by the 30th, and also just finally to note those risks that are in the quality impact assessment. Thank you, Chair.
Liz, thank you very much. So a number of hands raised. Oh, keep your hands up so I can write them down, but the first one I had was Frida. So over to Frida.
Yeah, I just want to, from a primary care perspective on the winter planning, this may be more to Maddie actually and David really, who understand perhaps the intricacies of this. It's just in terms of the concerns amongst my GPs and the BMA actually for that matter, is the opening of core hours on the platform to 6:30 is going to put immense pressure on the primary care teams to maintain that, whilst that is a instruction from government and it will come open on the 1st of October. It is a lot of the big ask, and especially in the winter period, to expect that with no increase in capacity or workforce. I currently work in a practice in Ipswich that does open, and it is really tough. And I just want to point out that that is a risk. If there's anything that the ICB will offer on that, I don't know if there is anything you can offer, but I'm not entirely sure this will help our winter approach in primary care, that this instructions come from government, and the BMA will back that as well. I know there are negotiations with the government on it.
Yeah, do you want to respond to that, Liz?
Primary care has been considered as part of the alliance-based plans and the sign-off that we've had through that route, so I don't know if it would be appropriate to do that, Maddie.
So I think we obviously understand and acknowledge the pressures which the practices are under in terms of the forward contractual changes from October. There's been a series of workshops that have been offered, and Dave's been supporting those to help practices to make changes. We do. Obviously, the teams are also available to support practices with any of those change processes. As you'll know, Frida, whilst generally, as Liz has said, there are no new additional resources coming from national teams, we are looking within each alliance at what we can do to support practices through the winter period. Those conversations are live at the moment, and I'm not sure whether you've been briefed in North East Essex or not, but I would be very happy to do that afterwards if that's not yet the case. Dave's pointing. Sorry?
Can you involve Dave?
I most certainly can.
So, so let's take that as an action outside the meeting. Did you capture that okay, Tom? Okay. I'm going to slightly out of order on the hands raised, but given the subject matter, Dave, can I come to you next?
Yeah, thank you, Chair, and thank you, Liz, for the report. Just really building on Frida's comments, I think one of the key points of this is being able to monitor the demand that's out there. Have we got plans in place to how we're going to monitor activity and demand within general practice? I think moving to perhaps the online consultations might help more with that, but have we got plans in place, because we're not part of OPAL, are we?
No, I mean, there's obviously the... so one of the things that we're really keen to do in sort of managing urgent emergency care demand is we do have a platform called Shrewd. We're very keen to get primary care data onto that. That's the conversation that we'd continue to like to progress. Obviously, we do still have our command and control structures that are in place. There's a daily sick rep, primary care are represented there, and we're really keen to continue to make sure that that's not just a sort of come and sit at the table, but that passive, sort of active engagement in terms of the demand that you're genuinely seeing and hearing from the rest of the system.
Just to answer that, I think it's the inability to control that demand now from October that is the problem, because up to October the practices can control the demand to a point utilising the platforms, but now they can't, and that is the concern, and it's open to all for the whole day, which the capacity in most of the practices can't meet that demand.
Yeah, I mean, what I think a lot of the providers, most providers, will be experiencing that as well. But what I can say is that we continue to have really excellent integrated urgent care provision through our provider PPG, who provides the NHS 111 service. So they're obviously available 24/7, so I appreciate that's demand. We've obviously sort of had further engagement with community pharmacy, so for the first year they've participated in our winter pilot as well. But we can also see demand has been increasing in some of our urgent treatment centres and in sort of ED. So that pressure is you know, that's the reason really why I've highlighted it at the start of that paper. I think it's not just limited to general practice, it's across the pathway.
Okay, thank you. I'll come to you, Maddie. I know you want to come in, but Ewan, I don't want to put you on the spot, but perhaps after Maddie, you might give us an acute perspective, if you would be so kind. Maddie?
Yes, thank you. So I think, as Liz said, we really are looking at how we can evolve the understanding of the day-to-day demand within primary care. We have been able to have access to some data from one of our largest groups of practices over a period. That's, I think, a very good proxy, has been a very good proxy for what's going on because of the number of practices engaged in that and the accuracy of the data. And that does enable us to see the pattern. As Liz has said, I think that's supplemented by the kind of soft intelligence that we receive and we proactively seek via each alliance-based team. There is a very live debate going on about how we can sort of adopt an Opal-esque type system within primary care, and I think actually there's a great deal of opportunity to learn from Norfolk and how they've been progressing with some of that insight as well. So I wouldn't say our systems and processes are quite as advanced as they are in our acute colleagues' trusts, but I do think that we are progressing that and we will be able to spot those indicators and to act on them.
Go on, Frida. One more
last
go.
comment, sorry.
Yep.
Absolutely, Maddie, I totally get that, but we don't as yet know what it will be like from 1st of October. We don't know what pressures the GPs will be under as yet because they have no control over opening or closing down that platform from 1st of October. That's my point. We don't know.
The only thing I would say is that I do think, because there are a number of practices across Suffolk and North East Essex which have already adopted that system, that we have been able to watch the experience that they have had. We do understand how that can sort of go down and dip before it comes back up, but we can see how actually longer term it can be a highly effective way to manage demand. But we do understand this is a big change across primary care.
Okay, thank you, colleagues. Ewan, any thoughts?
A few. I mean, clearly, as far as the acute hospital is concerned, the successful managing of winter it relies on working across the entire pathway from the front door through to the back. We've got a lot of work going on. I mean, the reality, of course, is that we're doing this work all the time because the emergency care sector is under really quite significant pressure at the moment. Certainly, if you look at performance across the region and nationally, it looks quite a lot like winter at the moment. I mean, in addition to those normal things, we're commencing our vaccination programme 1st of October, making real efforts to ensure that as many clinical frontline staff get vaccinated as possible. You know, we've all seen over the last 2 or 3 years a significant downturn in that, but working really with our clinical leaders to try and maintain that as far as possible.
Okay, thank you. Frankie?
I'm so pleased you just mentioned vaccination. Thank you. So it's absolutely our job to work together to plan and anticipate what's going to be happening, and so we can be as ready as possible, and I commend some aspects of the plan, in particular the earlier identification of triggers. But the other thing that I'm particularly keen on is the prevention and demand management. And as Ewan just alluded to, what we can all do as healthcare professionals and people working across health and social care is get our own vaccinations. But what our entire public can do is think about how we can look after ourselves as well. And vaccination, and while I'm at it, stopping smoking, are the two things that can make the biggest difference to our population and for our health and care system going into winter.
Thank you, Frankie. Noted. I'm going to go Janet, Elaine, and then Ed. So, Janet.
Thanks ever so much, Will, and thanks for the very detailed report from yourself and also the partners that were involved, all the providers and alliances. My thunder was stolen. My question was about vaccinations, and I'm just looking for some assurance, and Ewan has given it from his perspective. But for me, it's a theme that goes through this whole report. If we can get the public and our staff vaccinated, we'd be on the front foot potentially. So I think my question is, how prepared are our providers? How prepared is primary care? And is there going to be a national flu campaign to promote this? Because that would go a long way to helping, I think.
Let me go to Liz.
Yep, so we have a very strong performance around vaccination in this particular ICB. There is a national flu and COVID campaign. They are both being rolled out at the moment, and we have providers across not just our acute providers that are supporting healthcare professional staff, but also through community pharmacy, through general practice. We continue, and I just want to thank Frankie for that support and sort of really encouraging public and healthcare provider engagement in that. So we do absolutely have that support. And also Simon, our communications manager, continues to do a really good job in terms of sort of advertising, not just vaccinations, but things that we can regularly be doing for ourselves. So the health checks that we can take as well. And the really important one, things that we're really asking the public to do this year is just to have a little think before you pick up that phone and ring 999, before you walk into ED or jump in that car, just think, is this life-threatening? Or actually, could I go and see my community pharmacy? Could I go and see general practice? Could I call NHS 111? Could I go online to do those things as well? So really encouraging appropriate use of those emergency care services.
Thank you, Liz. Now, Kath is on this subject, and are you on this subject as well, Lisa? Okay. Sorry, Elaine. I'm going to go Kath and then Lisa. Hopefully, go on, Kath.
No, it's just a quick note with regard to vaccination. So we've got, NSFT has got our next Trust Board in Public beginning of October, which is just after the campaign really starts. So our Trust Board members are going to be vaccinated on the day and to make it a really public thing. So I think my message is about the importance of leadership and visibility. So we can't just ask people to be vaccinated if we're not prepared to do it ourselves. So it's really about stepping up that leadership and presence and what we're asking of others, we do ourselves.
Yeah, and sorry, Lisa, Dave wants to support that, I think. Go on, Dave.
Yeah, absolutely want to support that. As leaders, we need to demonstrate that behaviour, don't we? I'm just thinking that the public is quite vaccine saturated at the moment, and are we thinking about other ways of encouraging our community to get those vaccinations? Our faith leaders, our teachers, our other people that actually probably carry more weight than a doctor saying you need a vaccination at this present moment in time. So I think we should be looking outside the box about trying to encourage our community to take up our vaccination rates via other routes.
I think we're seeing a lot of nods and agreement to this around the table, so let's take that as board general agreement and ask the exec team as a whole to, across all our system partners, to note and deliver on that aspect. Lisa.
And on that thread, I was just wondering about, sorry Louise, I don't want to put you on the spot, but about social care, because they are in contact with more vulnerable people than maybe the NHS is, and I just wondered, Louise, is there in social care the same kind of rigour around flu vaccination for your workforce?
I was just looking at an email that I commented on yesterday. We are actually exploring a voucher system for adult social care workforce at the moment, so we're just exploring what the options are in terms of cost, and we'll be rolling something out. So.
So work in progress.
Yes, it's
but,
very much at the end stage. We've got
but
the options.
Positive.
We're going to commit to it, yeah.
Going to commit to it. We've got that. Excellent. Thank you very much. Elaine, I'm so sorry. All yours.
That's fine. So I also thought this was an excellent paper, actually, and great to see the thoroughness in preparation for the winter. I just had a quick question around one of the pillars, assurance pillars, which was for the ambulance performance, and it referenced automated transfer from 999 to 111 where appropriate. It would just be helpful to understand a little bit more about that it's not kind of robots making decisions about people's health status, and if they do need a 999 call out, they will get one. It'd just be helpful if you expand on that a wee bit.
Yes, absolutely. So this opportunity really has come about as some work that we've been doing. So Suffolk and North East Essex ICB is the lead ambulance commissioner on behalf of the East of England. And we've been working really hard with E-East and the other 5 ICBs to look at opportunities to make sure that patients are receiving the best possible ambulance care that they can. One of those opportunities is really looking at where the public are calling 999, but through that assessment, which is managed by a call handler, so that call will come through to 999, a call handler will pick that up, they will go through a pathway, so it's a nationally prescribed pathway of questions, and that will determine the level of care that is supported. Now, C5 is one of those categories of calls, which means it's generally not life-threatening. It's something that can mainly be dealt with through or cared for through what we call hear and treat. So that doesn't require an ambulance, and it doesn't require necessarily the clinical support that E-East provide through their clinical teams, which is why I'm so pleased that we've been able to work with PPG, who is our integrated urgent care provider. They provide NHS 111. We did some successful testing yesterday. This has been months in the making. And yesterday we actually did that. We concluded that successful testing. So as of today, all of those C5 calls, once they go through that call handler and they have been triaged to be clinically appropriate to be classified as C5, will now automatically go over to NHS 111. So annually for Suffolk and North East Essex, that's 14,500 calls that will now be managed through our NHS 111 service, which provides that additional capacity into E-East to be providing the life-threatening kind of care that is required for those patients. And that's an example of a significant amount of work that we've done this year, which is based upon national good practice. So we're confident around clinical safety there.
Thanks,
Great.
Liz.
Thank you very much. Thank you.
Yeah, thank you. I'll go to Ewan and then Ed, and then we'll try and wrap this up. So, Ewan?
Yeah, Liz, can I just check that as we evaluate that, we make sure that it doesn't drive patients into emergency departments? Because it would be great saving work in the ambulance service, but if a significant proportion ends up going to emergency departments, it will actually make things more difficult for us as a system.
Yeah, absolutely.
Yeah, noted. Thank you, Ewan. And Ed?
Yeah, I was going to comment on the UCCH. It's a really great slide, and the co-location piece I know has worked really well in Norfolk, hasn't it? So I think that would be another gain. My question or observation, Ewan and I were at a chief exec's event last week, I think it was last week, and Jim Mackey talked about 2 things. One is that when he ran a trust, no child would wait more than 4 hours in an ED department, and he wanted to see that rigour applied across the health service. So I know we've swapped emails on that, but it would be good if we could adopt that approach locally. And he also talked about the importance of senior clinical leadership during times of particular stress, which is an obvious point, but it's just getting assurance that our senior clinical leaders are in that leadership role, stepping up, as Dave was talking about earlier.
Yeah, so generally our 4-hour performance across the 3 acute sites that we have is very good, and it's above that the 78% that is that end of year target for the support that we have. There is variation in the system, and that is being actively managed, but that 4-hour children's performance is particularly good. Senior clinical leadership is important, but also is sort of leadership and sort of that robust leadership in general. So this year, again, one of the things that Sir Jim Mackey has asked for is that there is an executive director lead from each organisation, so each NHS organisation. So that is Richard for the ICB. and senior clinical leadership is reflected in the board assurance frameworks that each of the provider organisations is also signing off, in addition to that which we have today.
Okay, thank you. So, colleagues, that was a really useful and rich debate, and a lot of points captured, and I would say generally agreed and supported by all board members. On that basis, we're asked to approve the winter plan today, but that approval is in three parts, really. First of all, the plan itself. Subject to acutes, did you say this week, Liz?
Yes, we're just waiting on board approval from NSFT, ESNEFT and West Suffolk, which is all due this week.
So subject to that approval, board approval here. We're also asked to approve the board assurance statement and then submission to NHSE thereafter. Is everybody content to so approve? Agreed. Thank you very much. In which case, deep dive, Lisa, send Suffolk, all yours.
Thank you. So colleagues will remember that there was in Suffolk the SEND inspection of the local area partnership back in 2023. Essex are still waiting for their full inspection under that new framework. One of the areas identified for priority action was around the strategic planning, governance, robustness and impact of governance, quality assurance, and the management of transitions and planning for adulthood. And the feedback wasn't just about service transitions, actually, it was about how we support children and young people in their life transitions. So when they have extreme stress at home, maybe family or school, or they see a deterioration in their health, how does healthcare and education wrap around that child or young person to support them in that transition? So as part of the monitoring process that we are currently under in Suffolk, Department for Education alongside NHS England carried out 2 deep dives to review the progress made in that one priority area. So they did a deep dive in the management of transitions and preparing for adulthood in May, and a deep dive on the governance and leadership arrangements in July 2025. The full letters from the DFE are on the Suffolk Local Offer website, and the link is in the paper, so if you want to read the full letter. But in summary, we demonstrated in transition that we have a shared commitment to improving the experiences so that moving between services becomes a seamless experience. But they found that there was highly consistent experiences for children and young people across the area. There were some examples of excellent practice, but they weren't universal, and that left many families feeling unsupported and isolated during those critical transition periods. The families and practitioners also described a cliff edge that many young people face when transitioning between services, and health services were particularly referenced within those, particularly at age 18, when children, young people are moving from a paediatric service into an adult health service. They recognise that health transitions work well within some specific services. For example, Zest, we have some really good practice, which is our young person service at St Elizabeth Hospice, but that's limited to small numbers of children and isn't consistent across all health services. So we had 9 recommendations, which I won't go through each one. You've got the paper to read, but I think the summary is about consistency. So how do we have consistent transition protocols across health and social care services to really kind of address that cliff edge? And how do we use the child or young person's annual review process to really proactively think about what transitions are coming up for that child or young person in their life, and make sure that we are wrapping around that child as they have transitions in their life? I'll just go on to the deep dive into governance and leadership as well, which then happened in July. And in summary, the review found that there had been significant improvements in relationships and developing a culture of trust within the local area partnership. They made other findings around partners not fully understanding where they fit within the governance structure and communication not being felt universally. So again, we had 8 recommendations following that deep dive, which was to continue building on the relationships that had started to develop. Look at how we establish really good feedback loops with children, young people and families. How are we listening to children and young people? How are leaders demonstrating that they understand the experiences that children and young people have? Evolve the communication strategy and really focus on outcomes, which is all work that actually we already had in progress. So the local area partnership response to the deep dive findings, we have our accelerated plan, and we're just coming to the end of phase 1 of that accelerated plan, which is really focusing on revising and refreshing the SEND strategy and how the SEND strategy feeds into our governance arrangements. We've refreshed the governance arrangements. We have an independent chair for our Suffolk Improvement Board, who was recognised, again, if you look at the full letter, was recognised as being an excellent leader for Suffolk SEND and has really made sure that our progress is constantly challenged. We have appointed a communication lead within SEND Suffolk for the local area partnership, and we have just signed off our co-production charter across the partnership. We are developing a consortium approach to hearing the voice of the child and young person. So in a similar way that we learnt from our women's health work, where you can have a consortium of voluntary sector organisations, statutory partners and public, we're taking a same approach. So we will have a real wide range reach across children and young people to ensure that it is more representative and reflects more children and young people's voices, and we'll be ensuring that we co-produce everything with our children and young person consortium. Pathways, we continue to make sure our pathways are across healthcare and education. We are recruiting, preparing for adulthood strategic lead. We're just in that recruitment process at the moment, and once we have that person, the development of a PFA strategy and board. Phase 2 of the accelerated plan will build on that and really be very much focusing on our children's outcome framework, which we are developing, and again looking really at how we work in partnership to co-produce strategies and plans. So I just wanted to come on really for the key issues and risks for health relating to the deep dive reports. There is a real need for consistent transition protocols across health, and I've had a lot of conversations with each provider around how we're going to develop those. We are incredibly lucky that we have 3 SEND exec leads across our providers, so the 3 chief nurses in Essex, West Suffolk and NSFT have really grasped the mantle of being the SEND execs within their organisations, and we've had a session with NHS England to really think about how we bring the providers into the SEND leadership and government arrangements. I would urge health providers to make sure they understand how children and young people experience transition within their services, and to make sure that they are benchmarking themselves against the best practice guidance. So we have NICE guidance, we had a thematic review, which again the links are in the paper. And I think the other part that I just wanted to mention is our health steering group. So we are setting up a Suffolk Health Steering Group, which will be established as part of the SEND governance. We will oversee progress against the health risks around transition through that group. That will then report into the ICB Quality Committee, and the SEND Improvement Board will jointly report into both this board and council for the local authority. Thank you.
Lisa, thank you very much. And just before I open it up for general questions, you touched on this, of course. This is a lot of work, and actually possibly a continuous or maybe never-ending stream of work, especially given how important it is, and I know that board members agree with that. When would the board when would be a sensible update point for the board to get a check on progress, Lisa?
So I think the next real key milestone will be our monitoring visit, which we are anticipating. So we have a stock take in October by the DFE, and then we have a monitoring visit towards the end of the year. I think it would be helpful to bring an update following the stock take, and then obviously the monitoring visit will probably be about 3 months later. So I think probably at a quarterly basis we can start to bring updates through.
Okay, so maybe it might actually be the way the boards fall. It might be the March board. Can we put that in the forward plan, Tom, please? Thank you. Thanks, Lisa. Okay, colleagues, any questions for Lisa? Otherwise, we're asked obviously to note the report, the content. I think we should record in the minutes how important this is to the whole of our system and the people we serve in the public and people we serve in our system, and how this lays the groundwork going forward for hopefully generations to come. We're actually asked to approve the actions for health organisations, and the key word there is actions in the plural for organisations in the plural, to address the risks which the deep dive identifies. So that's what we're going to be asked to approve in a moment. But Maddie?
Thank you. And my question is to Lisa, and it's on the point of action. So just reading this and understanding how absolutely crucial the transition element is in particular, I suppose it made me think, what can I do in my role in Ipswich and East Suffolk, working with GPs and community services? So I suppose I just want to put out that offer to have conversations with the right people about how I can support this programme of work in really practical ways.
Is that an action? Sorry to suggest something. Is that an action you can take outside the meeting together? And it might not only be with Maddie, of course. Colleagues in similar position. Yeah. Okay. Thank you. Any other comments? Otherwise, we're asked to approve per the recommendations and the summary I gave. Happy to approve? Done. Thank you very much. In which case, item 10, the Res and Des, EDI, Inclusion Action Plan, and so on. Amanda, over to you.
Thank you very much indeed, Chair. I'm really pleased to be joined this morning by one of our staff network co-chairs, Gareth. And at the end of the presentation, I'll invite Gareth to say a few reflections on the work thus far. But here today we have our workforce race equality standard and our disability equality standard that we are obliged to actually discuss as a board along with our action plan. And if following today we approve, it will then be published on our public-facing website. So, in terms of the last year, we have actually continued to work really hard to focus on all things race and disability amongst our workforce. And since we discussed this very issue last year as a board, we have seen some positive changes. And they are shown in the report under section point 2. And I've identified 6 from the attached reports, which I'd like to talk us through to begin with. So as we can see, one of the positive changes is the management support that we provide and continue to provide to our disabled staff. And we have seen an increase in the last 12 months. We have also seen reduced pressure to work when unwell, and we deem that as a positive movement over the last 12 months. And we also have seen a managerial behaviour and support uptrend as well. We have also seen in the last 12 months a decrease in ethnic minority staff experiencing discrimination at work from either their manager or a team leader or indeed other colleagues. So again, a positive reflection in the report. And we've also seen an upward trend in opportunities for promotion and career progression. So indeed, that's something that we are very proud of. And finally, better than average satisfaction rates. So in summary, they are our 6 reflections that I've pulled out from the attached reports. The downside is there are 3 key issues and risks that we are very much aware of and continue to work with our staff networks, which I'll come on to in a moment, but they are very well known to us. But by way of example, the 3 that I've pulled out from the attached reports is a disparity in career progression. So that's something that we need to actually own and do more work going forward. The harassment amongst our ethnic minority staff with a long-term condition has increased as well. So that's something that we really need to understand and action in more detail. And we've also seen, sadly, a reporting of harassment from disabled staff drop. And through the Ability Network, we are starting to understand why is that, so we're working with our staff accordingly. So that's on the downside, but I'd like to now reflect on the last 12 months and some of the active achievements that we have continued to drive forward, and they are shown in the report under section 4. And as you will see, we have really tried hard with targeting our approach to all things equality, diversity and inclusion training. And we've actually seen over the last 12 months 164 staff take advantage of that, and we are really proud of that. And we need to obviously continue to drive that forward. Keeping with training, we've done a hard push in terms of mandatory training. Thank you. Apologies. So in terms of mandatory training, we have seen an uptrend of about 12%, which we think is really good. And this time last year, we were reporting about 82% compliance. We're now reporting just over 95 compliance, so a positive in that regard. We've also expanded our staff networks, and as we can see in the report, we have recently introduced a carer network and a neurodiversity network. And each of those networks is well attended. I think last count we had nearly 70 members of staff be director sponsor. So I think that underscores the importance we collectively play in terms of our staff networks. To support collaboration and that continuous improvement, we have, over the last 12 months, developed a community of practice within the ICB and the wider system, and they come together every few months, and we have some positive engagement, sharing of experiences to really improve our agenda moving forward. And in addition, each directorate has taken more ownership, and this is something that we actually took as an action when we discussed as a board about a year ago. And as a result of that, each directorate has had team meetings and conversations to consider 2 things. What more can their directorates do individually and collectively to support the EDI agenda? And secondly, what further actions can they take to strengthen their contribution? Because it's not just one department. ED&I is everybody, all of our responsibilities, and we need to acknowledge and action accordingly. Going forward, we know there is a lot of work that we need to do, and we will continue to drive this forward. And what we want to do as we move into our transitioning and new organisation, we want to actually strengthen the work thus far, but also we want to take our learning and what more we need to be doing into the wider, broader system. And indeed, conversations and more have happened very recently with our colleagues in Norfolk, and that has been positively acknowledged and more, and Gareth may want to say a bit more of that in a moment, but we're really pleased how Norfolk are embracing and wanting to work and wanting to learn and share, and how we can broaden the staff networks across Norfolk too. So in summary, Chair, I think we can be proud of what we've done over the last 12 months. We have had some good, positive outcomes. We acknowledge there is more we need to be doing, and we are not complacent on that. And I think through the establishment of our increasingly brilliant staff networks and how we can take that into Norfolk, we will truly be in a better place going forward. Before I take questions from the board, I would like to really allow Gareth to give his personal reflections, because Gareth has been a Trojan and has been brilliant supporting me in the Ability Network space.
No pressure there, Gareth.
Yes, thanks, Amanda. I just wanted to say thank you for this opportunity to be here with you all today, but there are some points here that I'm actually really, really proud of. So if I refer to 2.2, then managerial support for disabled staff, then I've actually had some managers come and speak to me and ask me how they can help encourage their staff, and how that level of psychological safety leads to staff being able to thrive. And it's better for the organisation, but it's also better for them, and I'm really, really pleased with that. That's incredible. In regards to 3.4, then reporting of harassment by disabled staff, which has dropped, which is, again, a really incredible statistic there. And I think that's because through training that's been provided, there's better understanding and more support available, we're able to reduce any issues before they arise and progress any further. One of the things that's really key is it's shown that the benefit of the networks and how it allows people to come to a meeting, and even if they don't feel comfortable to talk in a group, they can come and talk to us individually, and it gives them a place to feel psychologically safe and get their point across, and we can then discuss it with them and take it further if required and get a happy resolution. One of the things that I'm really happy with is the conversations that I've had with the Norfolk and Waveney staff, and they've invited me to their EDI support group going forward, and that's a really positive step that I'm really keen to take up on. And just the support that we've had from Amanda and all of the other exec chairs has been fantastic, and working with the other network leads has been brilliant, and long may it continue. Thank you very much.
Okay, thank you, Gareth. Thank you for that update. So I'll start with Dave, then Richard. So Dave.
Yeah, thank you, Chair. Thank you, Amanda. Thank you, Gareth. A really good paper, and it's interesting to see the good metrics that are improving. It's really just an extension of some support from the Suffolk and North East Essex Training Curve, who have partnered with one of our anchor organisations, the Eastern Colleges Group, to offer free active bystander training, so we can access it free. Please come and approach us if there's anything other things that we can support you with in this agenda.
Oh, thanks for that offer, Dave. Thank you, and noted. Thank you, Richard.
Not a question, just more support. So I think this is incredibly powerful paper, and I think there's so much more we can do with this. I'm really pleased that we've absolutely embraced this. And obviously we're going into a period of uncertainty for our staff in terms of moving into the new ICB arrangement. So I think our networks can absolutely support us, and we support them through this. So with Lisa, I'm sponsor for the LGBTQ plus network, and it's been incredibly helpful just to get insight into what some of the challenges someone who identifies with that community face, and all the different experiences they've got. And it's actually led to particular focus on the transgender community and what we need to do, not just for our staff, but for those that we serve. And so we've got some work happening in primary care, for instance, as a result of the fact that the network came about, which is amazing. We also need to think about Essex. So that is one thing that's come up through our work, is we want to make sure we transition successfully into Essex as well as Norfolk, and how we can work with the new ICB coming into place there to make sure that this is a key part of their thinking around the future. But thank you, really helpful.
Yeah, thank you, Richard. Ed?
Yeah, I'm going to say something similar. I mean, some really good progress, but lots of areas where I feel really uncomfortable about reading it. So, it's not a sort of thank you and receive. It's a lot more to do, isn't it? So, but there are some encouraging signs. I mean, as Richard said, the staff are under a lot of stress, and it's going to be a very stressful period going through the recruitment process, isn't it? So I think we need to support this work in every way, and in a collaborative way, as you say, across both ICBs. The other element is obviously there's a lot of tensions in the country at the moment, we've seen rallies in London, we've seen flags, we've seen all sorts of strong views being expressed. So it's just, this couldn't be more important, I think, at the moment, to get this right and to keep progressing.
Okay, thank you, Ed. Frida?
I was going to say the same as Ed just said. I just want to say, actually, that I think since the early days of when we used to meet about EDI, if Amanda remembers, we've come a long way, I feel, if that makes sense. And thank you very, very much for that, because at the beginning it did feel that we had a lot of work to do, and I know there still is, but I think we've come a huge way, and thank you so much for that. Just going on what Ed says, as a woman of ethnicity, I am alarmed by what's happening in the country at the moment, so it's really important that we don't other our colleagues, even more so now than before, because it's feeling really making people feel, like myself, very vulnerable in our own country. And I think it's really important that we're alert to feelings such as that from our ethnic and trans community, etc., that are being othered enormously at the moment.
Thank you, Frida. Yeah, and a lot of nods around the table when you were speaking there. Let me go to Susanna and then I'll come to Chris.
So just to say, I mean, well done on creating an environment in which people can talk about so many kind of uncomfortable issues. This builds really well on the work that we've done in the broader system around uncomfortable truths. And, you know, that approach of really leaning into some of these difficult issues. You know, as Ed says, you know, we need to remain uncomfortable about, you know, the issues that are kind of reflected here, but at the same time, you know, really reflect on what we've learned about how you know, can begin to chip away at that and make progress in this, because, you know, for all of the reasons everyone's mentioned, you know, times are difficult at the moment, and, you know, we need to kind of, you know, keep talking with each other.
Thank you. Chris?
Yeah, thank you. I think it's a very good report and good to see the tremendous progress that has been made. A few meetings ago, there was a mention about the representation in terms of the numbers within our staff of other communities. I just want to know whether there's any indication whether it has improved or changed since we saw it last time.
I think that's a really good question, Chris, and I remember the conversation very well a year ago when we were actually in Colchester, I think, at the time. I think we've seen variation and pockets, and try our absolute best when we recruit not to just rely on the recruitment traditional methods. I think there is more we can do to reach into our communities a lot more deeper than we currently do. It's hard, but we won't be beaten, and I think we just have to continue using our networks, the broader communities, and really reach into them in more ways.
Okay, thank you. Ewan? Did you want to come in, Ewan? No, you didn't? No? Okay, it was a rumour. I caught you. Okay, any other comments or questions, colleagues? Thank you. I think that discussion emphasises how important this subject is to us all, both individually and as a board, organisationally, and to our population. So we're fully behind this report. We approve the contents as we're asked to in the resident reporting, and we approve the action plan as presented. Agreed? Done. Thank you very much. Thank you, Amanda. Thank you, Gareth. Item 11, please. Key priorities for quality. Lisa, you're going to tell us all about the DASH review and the 10-year plan, I believe.
Thank you. I've included the NHS England PowerPoint presentation that the national team have been using to demonstrate Penny Dash's review. So you'll see that the overview slide kind of at the very beginning talks about why Penny Dash was commissioned by the Department of Health and Social Care, because there was concerns about a fragmented and overlapping quality system, and her review revealed a cluttered landscape of patient safety organisations that she felt were duplicating efforts. overwhelming NHS staff with recommendations and failing to deliver proportionate improvements. So as part of the NHS 10-year plan, there's an interface between the work that Penny Dash has been doing around quality and the operational delivery of the 10-year plan, so that we have a rigorous focus on high quality care and a renewed emphasis on patient and staff voice. And you will see represented throughout the slides with the recommendations and the enablers of care, transparency and public and patient voice is a really critical and important part of Penny Dash's review. So her key findings found that there had been a shift towards safety, but there were a plethora of organisations, reviews, inquiries and recommendations. There was limited strategic thinking and planning around improving and managing quality. And I think we would all probably recognise that there are significant numbers of reviews and inquiries that we have which actually don't always yield the gains that we would like to see. We are sometimes overloaded with reviews, both locally and nationally, and there's a huge amount of energy that goes into the investigations, into the reviews, and then less energy sometimes, and this is my personal opinion, that goes into evaluating, making sure that the actions are taken forward. So I think one of the things that Penny Dash was trying to highlight was that we needed a system with maybe less reviews but much more rigour around quality improvement that then realised the review recommendations and had a really strong evaluation component. She found that there was a large number of organisations in user experience and advocacy and a confusing complaint system, and she certainly made a number of recommendations around how we need to improve our complaint systems. An underuse of data, tech and AI. So one of her key findings was that other high-risk sectors use real-time incident reporting and analytics. And actually, Elaine will know from Quality Committee, the incident data that we look at is often months out of date. And we're not looking at actually what's that real-time incident data that we need to be using to make changes now, not looking at things that happened in April, May, as we're kind of looking at the moment. There was no national quality strategy for social care, so no national data collection of provider-level clinical social care indicators, which again feels like a real need. So she made 9 key recommendations, which you can see on slide 4. I won't go through them all, but just to kind of pull a few key points that I think are important is we will be having a new quality strategy which will agree core quality metrics, which again I think is something that we are really in need of. We really need to update and modernise our quality metrics, and part of that work is looking at how we define quality. So how do we still have the definition of quality which uses safety, effectiveness and experience, but actually what we know from our patients and our public is access to timely care is one of the most important things to them, but it's not actually at the moment within our agreed national definition for quality. And there's many other recommendations around streamlining staff voice, patient safety commissioner functions, reinforcing commissioner and provider responsibility and accountability for quality, and clearer governance and accountability as part of an operating model which we're all really looking forward to receiving. And again, how do we use AI? Everybody's talking about AI at the moment, but within the world of quality management, how are we going to use AI to identify poor quality care and optimise intervention? So I'm not going to go through the 10-year plan, you'll be pleased to hear, but it does kind of provide that backdrop for where quality interfaces with the 10-year plan, particularly around the innovation technology. So on slide 7, there are many kind of key points. It really focuses on the lack of transparency, on quality of care, which makes it difficult for patients to make informed decisions. So better data, better routinely collected feedback about public experiences, and really evidencing how we're going to use that data to improve our services for patients will be critical. Investment in technology to support, enable, and clearer incentives and accountability for leaders. There are 3 areas which we will really be focused on to bring about this new transparency of quality of care. The first is power to the patient through transparency, voice and choice. We've seen the league tables published. There's going to be more focus on patient-reported outcome measures and patient-reported experience measures. Maternity indicators, we're already seeing the new MOS being brought to our LM&SBs, our local maternity boards. That's a new quality metrics that we're looking at maternity services through. There will be a DHSC Director of Experience, and as I said, we're going to have some really clear direction around improved complaint processes. I think providers will be really pleased around the improvements required by CQC in receiving the feedback and written report following inspection, which will really help. We know that a lot of providers wait a very long time. One of our providers has been waiting 10 months for their official report following a CQC inspection, so that feels really important to get quick turnaround in quality improvement. The second area is clearer accountability and stronger incentives. So as I said, new quality strategy which is being developed by the National Quality Board, and the NQB will be responsible for oversight of quality measurement, transparency and improvement. We will see new modern service frameworks, patient power payments, I won't go through all of those details. The third one is streamlining regulation to focus on quality of care. So the national AI-led warning system and a more intelligence-led CQC model. So I'll probably leave it there, and I think we're in a space at the moment where there over the horizon is going to be all this work, and we're just kind of waiting for it. We've had some kind of sight on what may be included within the new definition of quality, which looks really exciting. I'm really welcome the transparency of care approach, the much more emphasis on quality improvement and not just quality investigation, the real power to patients. We've known for a long time that Healthwatch has given us a huge amazing insight into our populations, but our other ways of collecting patient feedback has not been as it should be. We've been very reliant on friends and family tests, complaints and PALs, and we really need to change and think about how we do that. And also patient-reported outcomes. So as we look at our strategic commissioning environment, really focusing on measurements of patient outcomes and not just service outcomes. So how do we know that patients are achieving the outcomes that we want them to achieve within those services? So I think there's lots of great stuff around the corner. Thank you.
Thank you, Lisa. And I'll come to Janet, but you're on the National Quality Group, aren't you? So perhaps I could ask you for some comments in a moment, if I may. But Lisa, what would be the next steps from the board's point of view here? Where do we go next?
So we have a meeting, a national meeting tomorrow to start to get the draft details of what the quality strategy looks like. And I think for us, it is about making sure that we're interfacing that with the planning round that Richard presented earlier. So how are we bringing those new definitions and this work into that planning round? And then I think the first real step will be once we've received the quality strategy, which I think Richard might tell, I think it's March, we're expecting it. We will need to then revise our quality strategies, our ICB quality strategies. Providers will need to align, we'll all need to align our quality strategies so that then we will have a really coherent quality management approach for planning, improving and understanding care, and we'll have a defined set of quality metrics. So I think we'll use the draft work to inform the planning, but the quality strategy in March will be the real key milestone.
So March update and maybe a sort of 6-month recurring, yeah? Okay, thank you for that. Janet.
Thanks, Will, and thanks, Lisa. There's nothing to argue in this. It's all very clear to me. And I think we've maybe touched on it a little bit. My thinking is about the future and who's responsible for what and how we design our future assurance processes and strategic commissioning in the new organisation. And it feels to me there's maybe a misalignment on timing on that. So it's just some assurance on what we're going to do in the interim till we get to where we're being asked to be.
I think this transition period has challenges as we transition responsibilities to regional teams, and also as we look with our blueprints and how we're going to work with our providers. So we currently have a quality operating model, which has always been my Bible, which states through every quality function what the provider responsibility is, the ICB responsibility, regional and national team responsibility. Now, we haven't had the finalised, updated operational model which clearly delineates quality functions across those 4 parts of the quality system. However, we have agreed regionally what that will look like. So as ICB dons, we've been through the quality functions, and as best as we can, in a bit of a grey area at the moment, we have agreed where our quality functions will sit, which, as you say, is really important for us, looking at what will our teams look like in the future. I think the reason that this review is really helpful as well is because in quality we've been very person dependent, and we need to move to a much stronger governance process and data informed. Our quality work hasn't been as data driven as it should be. We've been very reliant on more narrative, so I'm really looking forward to that, Janet.
Okay, so work in progress. Let me go to Ed, and then I'll come Ewan and Frankie.
Yeah, thanks, Lisa. Is there this is a lot to take in, but is there a parallel process for social care as well being developed around quality? You'd want the two to be talking to each other. Yeah.
So obviously social care is referenced within it. We were talking at the children's in Suffolk Children's Strategic Board the other day about how the quality definitions and the quality work needs to align with local authority. So I haven't seen anything in the national work, but I think locally it's something that we need to, as we kind of look at joint commissioning, brokerage across our functions, making sure that we understand quality in the same way is really important. So I think we'll probably have to take that off. Sorry.
Do you want to come in, Louise?
Good question, Ed. I was going to ask the same. I agree. A lot of this resonates with exactly what we're experiencing in social care, and it would be really good to join up early. And yeah, happy to be involved together on this, because we've got shared providers. The CQC element was really true, really resonates, and the AI opportunities together as well.
Can you take that as a after meeting join up?
Neighbourhoods.
And neighbourhoods, absolutely. Yeah. Great. Okay, thank you. Ewan?
Yeah, so I'm one of a number of chief executives who are supporting the quality work stream of the 10-year health plan. There are sort of four main pieces of work, one of which is the revamping of the quality board and the developing of the quality strategy. There's some work on developing modern service frameworks. The first three of those will be around cardiovascular disease, severe mental illness and sepsis, clinical standards, particularly focusing on acute services, and then the rollout of the maternity outcome signal system, which is due to be rolled out next month. So probably can't say any more at this stage about what's going on in those groups.
Okay, thank you for that update. Frankie?
Thank you. I'm delighted you're on the board because I can get my two penneth in with you as well as Aidan Fowler, who I'm always grabbing on it. So I'm very, very pleased that we are addressing the cluttered landscape where we're tripping over recommendations and actions without sufficient time or focus on actually achieving them. But there are two other things that I'm really keen that we do through this opportunity. At the moment, despite our talk, we often wait for something to go wrong and then learn after it. And we extrapolate from the one episode of a disaster and change everything on the back of that. And we're not learning enough from where things go right. So that is one aspect that I really want to see grown in the new framework. The other is Lisa's talked about AI. I'm very keen on us using the soft intelligence to triangulate with the hard. And there are some fantastic examples of where, for example, the early warning signals are on Mumsnet. They're not, people aren't going to PALS, they aren't going necessarily to Health Watch, but they are going to their friends and they are going online. And actually, those tools are available to us. We can pull that soft intelligence and triangulate it with the incident data. And I think that's where we will get an enormous wealth of opportunities for improvement. So I've already spoken to Aidan about this, but now you can as well.
Sorry, just to clarify, I'm not on the quality board. I'm supporting the quality work stream of the 10-year health plan. So sorry to be a disappointment.
Okay, that's a really interesting point. Was that Aidan Fowler you were referring to? Yeah. That's a really interesting point on the soft intelligence capturing, though. Are we doing anything on this actively ourselves at the moment, or is that something you could? I'm looking at Richard. Whether I'm looking at the right person or not, I don't know.
He's always on Mumsnet.
Yes, I wasn't meaning you personally.
If the Hadley Facebook group's got anything to go by, there's a lot of intelligence on there.
I think Maddie's going to give us the answer. Come on, Maddie.
No, not at all, but maybe just because that is very material. And we have staff living and working in every community, I think, across our area. And they do share and they see these groups as well. And there is a lot of learning that we can bring together. We have a lot of other soft mechanisms. Our bus that goes out into, the most rural, remote communities and is in inner Ipswich, and they learn so much just by listening. And I think strengthening those mechanisms by which we bring back those voices is what's absolutely crucial. And I'm not sure we've got that in a systematic way yet.
So it's the capturing and learning from, as Frank, Is that something we could take as an action to look into and report to a future board on how we're actually maximising that opportunity? Yeah. Should we take it that way? Yeah. Who's going to pick up the action on that? Where's that going to fall?
I think it's probably across, I'm happy to lead on it, but it's probably across all of us because it's actually, it's about how it feeds into all of our portfolios, so primary care, UEC.
Are you happy to lead on it?
I'm really happy to do that. We've got some real, places like Maternity Neonatal Voices Partnership, our parent carer forums, we've got real areas of where we do this work really well. Obviously the work that Health Watch does with us is incredibly helpful to give us insight into particular areas, but And NSFT are kind of ahead of the curve with the patient experience and how you listen to patients and users. So I think we've got some really good examples, but we need to make sure that it's a structured approach, so it's across everyone. Yeah.
And Tom, can you capture that as an action that Lisa will lead on? Richard. Oh, Richard, sorry, I missed you.
I'm glad Lisa said that, because when the strategic commissioning framework comes out imminently, we are going heavy on that. So there is an expectation that ICBs will be doing exactly what Frankie and you've just talked about. So it'd be good that we get ahead of the curve in terms of, so what is our plan to make sure that we're doing that?
That would be great. That would be great. And you're talking this afternoon to a national chairs network on strategic commissioning, aren't you, Richard? So I'll be all ears when I'm listening to that. Thank you. Suzanne.
So I was going to pick up on the points that Frankie raised about the importance of kind of soft intelligence. We do have places in the system where we create a space for people to talk, where we're perhaps less structured in terms of what we're intending to, we're expecting to hear. So we're listening, if you like, for maybe something we're not expecting to hear. So things like our People and Communities Assembly is an ear out into the system. But I really wanted to underline the importance of differentiating between knowledge and understanding. I think we can know an awful lot of things around quality, but not necessarily understand them unless we lean into some of those difficult conversations. And we've got to make sure that we continue to have the relationships and the spaces where we have those conversations going forward. That brings me to, really just touch the point of the importance of Health Watch. Health Watch are an independent voice for people and communities. They've often brought our attention to really key issues. For example, the role they had in terms of raising the issues around dentistry, which then the system's built on going forward. And also their ability to kind of leverage the trusted relationships they've got, not so much with kind of hard to reach communities, but I would say easy to ignore voices system as well. And then lastly, I just wanted to just highlight the importance of people's experiences of encountering the health and care system as opposed to individual providers as well, because very often many of the stories that you hear are actually about people just trying to engage the system collectively rather than just, their experiences with one particular GP or a particular hospital. It's bigger than that.
Okay, thank you, and noted. So, colleagues, despite that rich debate, we're actually only asked to note, but I think we're noting, endorsing the process and have agreed an action plan to actually develop of that data that we know is out there, how we capture it and how we actually use it positively. All agreed? Lovely, thank you. In which case, I'm going to move us on to item 12, which is the annual report and accounts. They've already been to board, of course, a while ago, July, I think, but now we're being asked to approve them for publishing specifically. But over to you, Richard.
Thanks, Jess. You'll be glad to know I won't cover the accounts. I could try, but I think I'll leave it to Howard for that part. So just briefly, we have a duty to produce an annual report and accounts detailing how we've discharged our functions. You'll see at section 2 in the paper, we outline the particular area overall plan that we've covered off. Breaking it down, you'll see further down, we've gone through an exercise of providing a performance analysis, so looking at the national standards that the ICB has been focusing on with our partners, and then the joint forward plan, so our annual plan around what are we actually focusing on, our priorities. You'll see there the breakdown again. There is some degree of crossover there. And we've broken down effectively which have we met, which have we not, and also which are we still on target to achieve. The later section also then talks about our health inequalities work, and it links through to the 2 county councils' health and wellbeing board strategy. But as you said, well, we've been through this, I think, a couple of times before, but I'll hand over to Howard just in terms of the annual accounts.
Thank you, Richard. All yours, Howard.
Thank you, Chair. So, yes, as Richard said, I'll focus on the annual accounts and our external auditors report. So the accounts presented are prepared for the 2024-25 financial year for Suffolk and North East Essex ICB. They've been audited by our external auditor, Ernst & Young, and they were scrutinised at the ICB Audit Committee on the 10th of June and approved at an extraordinary board, which was necessary due to the national submission deadlines on the 17th of June. So I can confirm to board that there are no amendments to inform post that approval. The auditor's report concluded an unqualified, unmodified opinion of the financial statements, and that they provide a true and fair financial position of the ICB accounts for 2024-25. They confirmed an unqualified opinion on the regularity of income and expenditure, which basically means that all our transactions were conducted within the ICB legal framework. And the value for money assessment concluded that no significant weaknesses were identified in how the ICB plans and manages its resources, ensures it makes informed decisions and manages risks, and uses information about its costs and performance to improve the management and delivery of services. The audit conclusions represent a very clean set of accounts with no identified material weaknesses or adjustments required. Chair, the ICB met its financial performance targets for 2024-25, including its duty to spend within its resources, which confirms our delivery of a £19.9 million surplus in that year, which was deployed to offset a deficit position in West Suffolk Foundation Trust. So my thanks as ever go to the ICB teams involved in the production of the annual report and accounts for their continually impressive diligence and professionalism. And I'd also like to extend thanks in public to Ernst & Young for their communication and conduct during this year's audit. I think, Chair, the board are asked to note the annual report and accounts. The approval happened on the 17th of June.
Yep. Thank you, Howard. Chris, as audit chair, would you like to add anything to that?
Thank you, Chair. The audit committee scrutinized the accounts and met with the auditors, and it was a very positive outcome for the year, and the auditors have confirmed that everything has been done appropriately, and the audit committee is happy to recommend it to the board for approval.
Yep. Okay. Noted. Any questions for Richard, Howard, or indeed Chris? Otherwise, as a board, we're actually asked to note, but in that noting we'll also be agreeing the publication thereof. All agreed? Done. Thank you very much. Thank you, Richard and Howard and Chris. In which case, item 13, Lampard Inquiry Update. Lisa.
Thank you. This is one of our regular updates on the progress in the Lampard Inquiry, and that the project team prepare for us and goes to each of the 3 ICBs that work in Essex. So the paper details the Lampard Inquiry and the terms of reference. It also details the timeline, and we are currently still in phase 2, where the inquiry is collecting evidence. The approach for the ICBs to work collaboratively is detailed, which I know I've presented before. We work very closely as 3 ICBs. Myself as the SRO for North East Essex, Beverly Flowers for West Essex, and Matt Sweeting for MSE ICB. And we have a joint programme team that reports into us, and we meet weekly as SROs. So this report really just wanted to give you an update on activity that's happened since the last update. And in May, we were informed that the inquiry scope had been updated to include learning disability and drug alcohol units. That came from some of the evidence that they had collected, that they had decided to extend the inquiry scope to include those units and to clarify the inquiry's definition of inpatient death. And there haven't been any further amendments since May to the inquiry's scope. The Lampard Inquiry publishes disclosure updates confirming the number of requests for information under Rule 9 or Section 21 of the Inquiries Act. Based on March 2025 figures, there's been 58 requests to organisations who are core participants, 72 requests to organisations who are not core participants, and 162 requests to individuals and families, and the ICBs have received 2 Rule 9 requests, one in July 24, one in February 25, both of which were responded to within the required time limits, which is incredibly important for the inquiry that we respond within the required time limits. So public hearings, there have been 2 public hearings, one April to May, which heard contextual evidence relating to the provision of mental health inpatient care, and then the 7th of July to the 14th of July, which was when the inquiry heard witness statements from bereaved family members, and all of those recordings are on the Lampard Inquiry website if anybody wanted to hear them directly. Future public hearing dates are within the paper. The next public hearings are 13th of October until the 30th of October, and we know that they will be further witness statements from family members. The way that the Essex ICBs work, we have a number of our PAN 3 ICB teams that are working together. So our commissioning teams work together, finance teams, quality and contracting teams, which is really important. The most challenging aspect for us as ICBs has been, because the scope of the inquiry is from 2000, has been retrieving historical data and from former commissioning organisations across the whole of Essex. That has been very challenging. And we also, it's really important to say, so that there are several groups with targeted areas of work. Safeguarding, we have a safeguarding process, so as the inquiry hears about cases within Essex, there are sometimes safeguarding concerns that are raised as part of that. So we have a clear process in which those safeguarding referrals can be made, firstly to the ICB, who consider and then decide to make safeguarding referrals onwards or not. And we've had a number of alerts, 24 alerts for those safeguarding referrals. So that's been a really good process that's been tested and includes the local authority. We have a communications, PAN ICB team that work together to make sure that we're all communicating consistently across the 3 ICBs, HR, information governance and historic records, and as I said, the SROs, we meet weekly. There's an area in the paper that talks about sample case review in September. One of the things that we spent quite a bit of time working with Mills and Reeves and our KC, and one of the things that we were worried about was with reorganisation and change of organisational structure in the future, we wanted to protect the inquiry and our ability to respond to the inquiry from any changes in our staffing workforce and changes to our kind of record systems. So we took a proactive approach to that, guided by Mills and Reeve, but agreed by the inquiry, where we have commenced a review of 6 cases spanning 2015 to 2023. And we will submit the statement to the inquiry prior to the next hearing. And reviewing those 6 cases has allowed us to describe the commissioning landscape at the time of the cases, how contracts were monitored. Obviously, they are very interested in how we've monitored contracts, how we've escalated quality concerns. They're very clear around their questioning of when a quality concern has been identified, how has that been progressed through governance, how does that feed into the contract process. So we really wanted to demonstrate how that's worked across that 8-year span. So we'll be submitting that, and it may become a formal inquiry Rule 9 request. So I think that's probably all I need to update you on. That's the work that's been happening over the last few months, and just asking you to take assurance on this oversight. Thank you.
Lisa, thank you very much, and I think we all recognise the huge amount of work that's involved here, and thank you and all those involved for it and your commitment to it. When is the next update? This work's going to go on for a while, isn't it? So next update would be when, Lisa?
I suspect it will probably be, I think probably I'm looking to Tom because he's incredibly important in this process for me.
January. Okay, so where are we now? September. Okay, so the board meeting after next January. Okay, colleagues, questions or points? Otherwise, you are asked to take assurance basically on the continued oversight. It's not our work, is it? It's the Lampard Inquiry's work, but oversight thereof, which is vitally important for future learning, of course. Content to approve and note? Okay, thank you very much. Now, Richard, performance report. Apparently the coffee will be available for our coffee break at 11 o'clock, so you might find that those doors, those flaps at the back of the room start to open while you're in this item, but I think you might be standing between the board and a coffee break, so can I come to you?
Thanks, Chair. I was hoping for a coffee and a loo break before, but I'll keep going. Thank you, Chair. So, as always, we've got the performance pack in the papers. Just briefly, to not keep you away from your coffee, the first slide just takes you through, I wasn't there, but other colleagues were, the last Finance, Performance and Workforce Committee. You'll see there we covered a range of items, particularly focused on finance and productivity, which Howard will cover later off, but also on operational performance and business planning, which we covered a little bit of that earlier in the agenda around the planning framework. To colleagues who've heard me speak before on this each time, the areas I'll highlight haven't changed fundamentally from what we've discussed previously, and we've also had the winter plan item earlier that also covered some of the challenges that we've got. So if I turn to page 132 in the pack, the colourful diagram in blue and orange, it splits it down as always into some of the main theme areas that we focus on. So in terms of urgent emergency care, our particular challenge areas remain at ESNEFT, particularly around the ambulance to handover delays over 45 minutes. So I'm on call this week, and I was on a call last night at 10 o'clock where we were talking about that. So it's very, very much prevalent at the moment in terms of the work we particularly need to be doing at Colchester to try and get a better handle on the challenges that we're facing there. But there's some really good plans we're talking about very early this morning to try and understand what we can do better on that. Over, to be fair, and Ewan might say more, still challenged, but is in a relatively good position in terms of particularly some of the changes that the Trust made in their A&E, which seems to have borne through earlier this year, in terms of having a much better understanding and much better flow running through, but still very challenged, as Ewan said, under the earlier item. If I turn to elective, slightly flips the other way. So ESNEFT are in line with their plans across pretty much all the metrics around referral to treatment, outpatients, diagnostics. Again, you may comment later, but in terms of West Suffolk, we are in tier 1 in terms of the elective work. So that effectively means we've got national focus working with us locally to understand how we can get our plans back on track over at West Suffolk. There was some improvement from last month to this in terms of something, so we are starting to see some green shoots improvement there, but there's a real focus on going to make sure, particularly going into winter, that we don't take our eye off the ball. I'm sure we won't in terms of our referral to treatment work, particularly in the context of the letter that Sir Jim Mackey sent out this week, really showing that across the country we are slightly behind plan in terms of our elective performance, and we need to keep a clear focus on it. Just briefly turning to cancer, a mixed story. So again, starting with the positives, we've seen good improvement at West Suffolk, particularly after the dip we saw in summer around their 28-day performance. So that was particularly being driven, as I've said before, by breast. That has really come back, and we've got some focus work we're looking to do collectively with the national team around really doing a review of the overall breast pathway over at West Suffolk. We have seen our 62-day performance slightly dip, so we are just below the 75% target, so we're in the early 70s. But we've got a focus meeting, I think, in the next couple of weeks with both trusts around that. I'm really pleased in terms of mental health overall. We were meeting 7 of the 8 national standards. We have dipped slightly in talking therapies. That's particularly related to EPUT rather than an SFT, and we've got a recovery plan that we're discussing with them in the next few weeks related to that. You'll see then there's far more detail in the pack where we unpack each of those areas in turn. And I don't know, Maddie, put you slightly on the spot, if there's anything you want to comment on primary care, as I did spot that wasn't in the pack this time.
No, thank you. I was going to do that because I think in the summarising of the pack, the narrative around primary care does seem to have disappeared and we just have 2 lines. But I did want to give the board assurance that the scrutiny of performance continues through each of the alliances, primary care commissioning groups and collectively as well. And overall, the experience and the access data is positive, as it's noted in here. And our focus is trying to support practices where there is variation. That's our absolute priority. I'll leave it there. Thank you. Happy to take questions, of course.
Okay, thank you, Maddie. Any more, Richard, from you? No, all done. So, questions, Elaine?
Thank you, and I appreciate there's a lot in the report, but I just wanted to pick up on the productivity area that we mentioned briefly earlier on, just really for some additional assurance, because I noted in the summary it says SNE not meeting the national 2% productivity target, nor the SNF West Suffolk Foundation Trust meeting the sustainability target that was set out as part of the McKinsey report. Now, mindful that that was quite an important part of being able to do the strategic shift, which we know is important, it would be helpful to just understand the actions, next steps and potential timescales to get that back on track would be helpful.
Go on, Richard. Yeah.
Defer to Howard.
Oh, all right, go to Howard. And Janet, does that cover your point? As I thought it might do. Yeah. Howard?
Yeah, so Elaine's right, obviously. So there's basically two metrics of productivity that are measured through the report. One is around respective changes in clinical workforce versus activity. As a system, we're doing slightly better on that. I'll talk a bit more about that in a second. And then there's the implied productivity, which is a simple measure of activity over cost, which is the 2% national metric. I think it's important to say at this point that nationally they're reviewing that implied productivity, and so apparently they're coming up with some new metrics that they'll be publishing in October. So they've recognised that's a relatively crude measure. And then there are other compounding factors that I think we just need to bear in mind, including some of the implementations that are happening in ESNF, for example, or in SEOC, EPR, and so on, which you'd expect to level out over time. And then there's been some counting issues with bank and etc. in West Suffolk. So it's a bit of a confused picture at the moment, is what I'm saying, first of all. I think what you can say is, first of all, that West Suffolk have definitely made more inroads into productivity gains this year than ESNF have. So I think that's positive, and is probably in line with, and maybe Ewan can talk a bit more about that, but certainly in line with the financial recoveries that they've had to go through over the last year. So in terms of keeping a lid on staff growth and so on. So I think we can say that. I think we can also say that I don't think are meeting the requirements of the sustainability review. The exact percentage is possibly up for debate, but I don't think we're meeting that sort of 5% target, which then implies that probably as a system we're not yet on that trajectory to get that financial sustainable position that we're looking to get to. And in terms of actions, I think I can say that there's been a fair amount of scrutiny at Finance Workforce Performance Committee about this particular issue. I don't think that there are a clear set of actions yet that will exactly set out how we're going to get to that sustainable position as set out in the McKinsey report. And I'm not clear yet what outcomes are coming out of the productivity board that's been set up between the two trusts. So I'd say a bit more work to do around the data and just being clear about exactly where we are, but I don't think at this point that there are a very clear set of actions to get to that sustainable position.
Thank you, Howard. Let me go to Elaine, and then perhaps you, and if you've got some comments to make, go on.
So thank you very much for that. Given it's such a complex sort of space and still quite a bit to be worked through, what would still be helpful, I think, is to understand the accountability, to make sure that there is a clear action plan. So it would just be helpful to know from the board perspective who's holding the accountability to get that action plan in place would be good.
I think the accountability sits with the providers on the, so that's meant to be that was meant to be going through the productivity board set up between the two trusts.
Yeah. Let's pick it up as an action outside the meeting to follow up on the on progress. Should we say on progress? Ewan, did you want to add anything to Howard's comments there?
Well, I think a couple of things. I mean, there are a whole range of actions that's coming out of the sustainability review, some of which sit with the ICB, some of which sit with the providers. So it's about, I think there's probably 6 that sit with the ICB, 4 with the providers. The next joint productivity board is on Monday. I think it's important that we all understand that the figures that came out of the sustainability review are reliant on a number of assumptions that we know not to be correct. So we know that worst case scenario around the revenue costs of the new hospital were included, savings to be delivered within the first 5 years, 2 years before the hospital's built. So I wouldn't obsess about the exact figure of productivity that's being delivered, because we know that some of those assumptions are not true. Yeah, it's a worst case that for example, we know some of the things about the assumptions around depreciation in the report are not the national position.
Okay, thank you, Ewan. Ed?
Nick isn't here to speak for himself. He normally is very confident doing that. But on the EPIC rollout, so I think to the credit of the trust, they're 3 months ahead of where EPIC expected them to be. But it's inevitably going to be very disruptive and a huge challenge for the staff to kind of transition to the new arrangements and to qualify to use the new system effectively. So I don't know what sort of a handle we've got on that disruption and how we can support SNF through that period. It was similar when West Suffolk adopted Cerner, I remember. So it's just a flag. I think this will be a very challenging year for SNF for lots of reasons.
Yeah, noted. Thank you. And no doubt that's something you'll pick up outside the meeting, Richard.
Yeah, Ed and I talked about it this morning because, as I said, we're not in winter yet, but the system is running very challenged. And as you said, it's the trust is absolutely focused on EPIC rollout, but has got to keep things safe, secure, etc. as they can. So Liz particularly is doing a sterling job at supporting, but we've asked them again this morning, is there more we can do to help them, particularly over the next few months?
Thank you, Richard. Tom, let's record the board noting those various points and the future, let's call it risk profile that it presents over the short and medium term, actually. Frida.
Sorry, I just wanted to point out that EPIC is also going to have a huge impact on primary care, just to say that it's across the system.
Yeah, noted. Good. Okay. Janet, yes.
Thanks, Chair. And I was going to pick up on the productivity work that the Finance Performance Committee is doing, and colleagues have spoken more eloquently probably than I am, but I would say this is the tricky, thorny issue that the committee is dealing with, and it's clear that there is a need for confidence in the numbers, confidence moving from what was in the sustainability review moving forward, and then the national view on it as well, which seems to keep changing, as Howard alluded to. So my view is, as chair of this, the committee that's dealing with it, I want to be in a position for the November board as part of this overall review to have done some new diagnostics, if you like, and give the current version of the truth in terms of productivity and a plan forward. I think that would be what I'm looking to get to a place for November.
Let's see if Howard's going to say yes or no to that.
Oh no, definitely. I think I just wanted to add that...
Is that definitely a yes?
Yes.
Good.
What was the question? Yes, sorry, I just wanted to add, although it sounds like a muddle when nationally they revise how they're going to count productivity, etc. But to be fair, I think they're trying to make it a useful measure. I think that's the critical thing, because in order for providers, for example, to understand exactly how and where they need to improve their product, you need to have useful information, and just having a very crude cost base over activity volumes doesn't really say or inform boards very much about exactly where and how they need to target their efforts, really. And I think that's nationally what they're really trying to do, and specifically what we're quite close to achieving anyway in SNE with respect to looking at workforce productivity through the work that Alex Royne is doing in Richard's team. So, and that reports regularly through to that committee.
And I would just add, it's really important that providers recognise the data that we're discussing.
Yeah, agreed. And we're agreeing November update, yeah? Okay. With that, happy, Elaine? Yeah.
Yes, I think that point about the making sure it's really clear, the rebaselining, and doing that, I suppose what it's good to do it this side of the year rather than we get to the end of the year and are arguing about what the baselining numbers are. So that'd be great if that update can come back in November. Thank you.
Okay, agreed. Tom will have captured that. Thank you very much, all. For the paper as a generalisation, we're simply asked to note, which we've done with some very rich discussion there. It is actually 11:05, well, 6 past actually now. What I suggest we do is take a short break. We've been doing this for just over 2 hours, and reconvene at 11:20. So short break now, please. Reconvene 11:20. Thank you. Thank you. That's echoey, isn't it? Is that me? Yeah. Are we ready to restart? All go? Okay, everybody, thank you very much for a hugely beneficial morning so far. So let's go into our final section with the finance report from Howard. All yours, Howard.
Thank you, Chair. So the SNE NHS system has a plan to spend £2.8 billion of allocated revenue resource in 2025-26. This represents an overall break-even position, which includes a £20.7 million planned deficit at West Suffolk Foundation Trust, offset by a £20.6 million surplus at the ICB and a further £100,000 surplus at E-East. As of month 5, that's the period April to August, the SNE system is reporting a year-to-date deficit of 1.5 million, set against a year-to-date planned deficit of 8.2 million, so therefore we are currently £6.7 million ahead of our plan. The majority of that 6.7 surplus is with E-East. This is due to a late notification and subsequently delayed delivery of spending plans for an allocated 12 million of capacity funding that was provided to the ambulance service to improve C2 performance. The Trust continues to assure that it has plans to deploy these funds in time for winter, and at the Finance Workforce Performance Committee last week we also decided to start drawing up a plan B for alternative use of those funds if it looks likely that those funds will not be spent. So there's Liz Maloney is already kind of working through with regional partners on that. The ICB itself continues to perform well against its plan and is on trajectory to deliver in this year with notable improvements in key risk areas such as prescribed drugs, CHC costs, which are both driving a 1.1 million overachievement on our cost improvement plan year to date. Not factored into the ICB position is the risk of potential redundancy costs associated with the changes in ICB. We are still awaiting notification from NHS England with respect to external funding. West Suffolk continued to perform well against plan and are £2.4 million ahead of trajectory. This is a very commendable performance versus the last 2 years of not meeting plans. The board just needs to be aware that this plan is more heavily weighted in the second half of the year. So the average run rate deficit per month currently is about £2.4 million. That will need to effectively halve to £1.2 million per month as an average over the next 7 months. The view of the Trust at the last Finance Performance Committee was that they believe that they have confidence that they'll deliver this plan this year, but there's about £4 million of residual risk that they're working through plans on. The board should also note that due to the current positive performance at West Suffolk, the Finance Performance Committee approved pausing the double lock expenditure control process at the Trust in August. That was in line with the approved terms of reference and of course can be reinstated in the event that the Trust starts to go off trajectory. ESNEFT are currently £1.7 million off plan, and as Ed alluded to earlier, the Trust is clearly having a very challenging year with respect to delivery against a range of very significant investments, including the new electronic patient record system, the orthopaedic centre and the Green Surgical Hub, as well as a reportedly difficult start to the year with respect to cost improvement plan delivery. Overall, Chair, I think I can say that the SNE system is well placed to deliver on its plans this year, notwithstanding significant risks on our acute provider sector and the uncertainty on redundancy cost provision for the ICB. I would imagine that the next 2 months are going to be critical with respect to performing, particularly as we start to see that the increased asset of West Suffolk, I think, over from the October period, and also the new EPIC systems coming into place in October and so on and so forth. So there's a lot of risks that will start to materialise in the October-November period that will be quite critical for us assessing where we're going to be landing this year. Just wanted to make the board aware that all ICBs, including SNE, are implementing a new ledger system. It's called ISFE2 from the 1st of October. This is a challenging, resource-intensive and complex exercise, as you might imagine, but the longer-term efficiencies and improvements in reporting are promised to be encouraging. Over the next 3 months, I just need to flag that our ability to report will be a bit more limited, and that's in line with other ICBs and expectations with NHSE. But I'm confident that our finance teams are well prepared, so we'll be well placed to see this process through in a proper fashion. Very briefly, with respect to the medium-term financial plan, as Richard said earlier, we are awaiting formal 3-year revenue allocations and 4-year capital allocations alongside a planning framework which will set out the expectations and rule book that we'll be working to for delivery. That has been promised for October, and hopefully that won't be delayed because we're working to some very tight timelines to get to agreed positions by the end of December. We are, however, starting to do some of the core groundworks, including we'll be starting to go out soon for a collation of future cost pressures. We're doing a bit of work with some external support to better understand our underlying deficit position, particularly as we move to a new Norfolk and Suffolk. So we're doing an independent assessment of both the Norfolk and Waveney and the Suffolk and North East Essex underlying deficits, and also effectively how each ICB has been spending its money since pre-COVID. So we should be able to report on that in the November board as well. And there's also been a substantial amount of work with a return due today, seeking to better understand the connection between the payments that we're making to providers through their block contracts versus what theoretically they would be paid based on an activity basis. So it's an indicative piece of work. There'll be a lot more questions that will be asked rather than answers, I would imagine, but I say that return's going in today. I would imagine there'll be quite a bit more work that will flow out of that, but again, we'll bring that back to November board as well to wash up. So I'll stop there.
Howard, thank you very much. Chris or Janet, did you want to add anything to that, Janet?
I think Howard has explained the work that we're progressing, certainly through the Finance Committee, perfectly. Thank you.
Okay, thank you. And nothing from you, Chris. Any questions, colleagues? Frankie?
Thank you. A question for you, Howard, but also perhaps for the next agenda item. The financial impact of industrial action. Of course, it was just a day or two after our last board that was our last round of industrial action, and we don't yet know whether there may be others. I'm just thinking about how we're preparing for that.
Yeah, sorry, I should have picked that up through the question, so thank you for flagging. For ESNEFT, they've estimated about £300,000 to £400,000 for the last round of IA, which tallies neatly with the, now that I'm privy to the numbers across Norfolk and Waveney as well, which is, it's a similar number to that provided by the Norfolk and Norwich, so and it's equivalent, I think, to the number also being stated from West Suffolk. So, and at the moment, there's a pretty clear line coming from National that there won't be any external funding for that, but we'll see what happens if there's further IA. So, yeah, thank you.
Okay, thank you. Ed?
Thank you, Howard. We're doing some work to understand the underlying position for the Norfolk and Suffolk ICB going forward. Yeah. Is there a similar piece of work happening in Essex to establish what their overall position might be?
Not that I'm aware of, no, but I'll ask the question.
Yeah, maybe you could take that as a prompt if you would, Howard. Thank you.
Because I think it would be good for North East Essex to be really clear on what they're going to bring to the table in Essex.
Yeah.
No, yeah, go on, Howard.
Just to say, yes, I'll definitely pick that up with the the Director of Finance, part of this work will also be looking to separate out the North East Essex element anyway, so we'll have a bit of that work done already, but yeah, not the full Essex picture.
Okay, thank you. Any other questions? Otherwise, we're asked to receive a note, and I think we also have Maddie, I beg your pardon, Maddie, go on.
Thank you. I was just going to ask in respect to the capital allocation, if we've got any indications to whether that will be a single block or whether it will be identified for particular sectors.
Are you talking about for future
Yes.
purposes? Yes.
Did you mention 3-year, 4-year capital allocation?
So they have said they're going to be changing the framework. So we've been operating recently under something called the CDEL, that's the capital expenditure limit effectively, and that's been based on a system basis. So they're saying they're replacing that, but they haven't said exactly with what yet. Yeah.
Okay.
But they have said that they're going to be reducing the some of the administrative requirements, which hopefully will make things easier on a primary care basis. But we'll see when the detail comes out on that.
I shall look forward to it. Thank you.
Richard?
I'm fortunate, I think, to sit on the National Planning Task Force, so if I get any early sight of some of that in confidence, I'll share.
Okay. So, colleagues, we're asked to note, I think we are noting and thanking all those in the whole teams indeed, across the system for the performance to date, but noting the increasing risk profile as we move forward, as Howard described. With that comment, are we happy to note? Done? Lovely, thank you very much. ICP update, Susanna.
Okay, so of course the role of the ICP committee is to bring together the full breadth of partners in health and care across our integrated care system, and some of you might have noticed that quite a number of those partners are currently experiencing some changes. So kind of taken overall, we're expecting the formation of new mayoral strategic authorities in both Essex and in Norfolk and Suffolk in 2026. The process of local government reform is working its way through. That will replace our current landscape of county councils and district and borough councils with a smaller number of new unitary authorities. Of course, we know about the fundamental changes to ICBs, moving to new footprints, significantly reducing their workforce and refocusing their role as strategic commissioners. The abolition of NHS England is transition of its role back into control of central government and new emerging role for regions. The decisions by government to abolish Healthwatch England and local Healthwatch organisations, the potential for some foundation trusts to become integrated health organisations, increasing challenges for our voluntary community sector and social care providers, and of course the decision by government there will be no statutory requirement for ICBs and local authorities to operate an integrated care partnership in the future. So quite a lot going on. Now, collectively, what these changes mean is that the way that we currently work as the Suffolk and North East Essex integrated care system will come to an end in April 2026. However, this does offer the opportunity for a kind of reset of arrangements for local health and care systems and partnership working in both the new Essex and Norfolk and Suffolk health and care systems. And so any of those new arrangements would, of course, need to be discussed and determined by all of those new key partners who will begin to emerge over the next year or two. So, a number of stakeholders have in the ICP have expressed their view that there is some useful learning in SNE, in particular, about how we've worked together as an ICS. And based on this, our 3 ICP co-chairs, so Professor Pope, obviously, Councillor Spence in Essex and Councillor Wiles in Suffolk, have agreed that it's really important that we ensure a space for and an opportunity for stakeholders to reflect on their learning during this last part of our journey as an ICS. So what I want to update the board on is that we're going to be, over the next 6 months, undertaking a ICS system learning and legacy project to focus on 2 important questions. The first is, what have we learned in SNE about enabling effective system working in health and care from our experience and our particular local interpretation of how we've worked together as an ICS? And then secondly, what do we consider the legacy from SNE to be that should inform a reset of how system working can be best enabled in a new emerging health and care landscape in both Essex and also in Norfolk and Suffolk, so we can share those things with partners. So that project's going to commence with the already planned next meeting of the ICP, which is on Friday the 10th of October. This will be an online workshop style session, but we're going to have some external speakers, so Professor Johan Fazy from the University of York, for example, and there'll be an opportunity for all partners to inform the scope of the project. And also, I think it's really important for some updates across the wider system partners on all of the change and the issues that I've just described underway. And then towards the end of that project, we will be organising an appropriate in-person celebration for the Suffolk and North East Essex ICS in March 2026 to share that report from our system learning and legacy, involving system stakeholders from the present, but also I think maybe should include some from the past as well, because obviously we've been working together in this way for actually the best part now of a decade. For stakeholders in Suffolk, we've begun working with Councillor Wymark and other colleagues who support the Norfolk and Waveney ICP, and we plan to bring together stakeholders from across Norfolk and Suffolk also in March to talk about how we can build on experiences from both systems in the future, and I'll be in touch with colleagues about that soon. So that's our system learning and legacy project, which is going to keep us pretty busy. But that's not all that we're doing. Over the summer, we've been operating an ICS summer school. This is comprised of 4 themed workshops around system working, around evidence-based practice, around culture and leadership, and also managing relationships. And we've actually had more than 200 individuals who have attended multiple workshops, and many of them have actually completed the whole set of 4 workshops. And those individuals have been from across both the Suffolk and North East Essex ICB and also Norfolk and Waveney ICB, but also voluntary and community sector, local government, the whole range of different sectors. So we're going to be expanding that work a little bit further. I'm not sure for how much longer I can call it a summer school because it's getting cold, but we will be adding some further dates, and also probably a 5th themed workshop on change and transformation. Together with the Health Innovation East and the Integrated Care Academy, we've organising a Innovation Day for the Suffolk and North East Essex system. That's the 29th of October. And a particular theme for that day is going to be on space-enabled health, and we even have a contribution from NASA. I kid you not. And then last but not least, we're really busy trying to find opportunities for stakeholders to begin to kind of get to know each other, particularly given the new footprint. So, for example, the ICB will be supporting at the Norfolk and Waveney ICS conference, which is up in Norwich on the 12th of November. So we're going to be there with both presentation, the stall, and some other opportunities for people to get to know each other. So that's it. Thank you,
Susanna. Ed?
Thanks, Susanna. I mean, the work you do is brilliant, isn't it? Always has been, always will be. The summer school is getting a huge amount of engagement in both Norfolk and Waveney and SNE, which is fantastic. And it seems to me it would be good if we could encourage as many ICB staff to attend, because I think they're getting a lot from it, and for lots of reasons. So maybe we could think with Amanda and others about how many schools you could provide in the coming months, because I think it's, the staff are getting a huge amount from it.
Winter schools, I think, coming up.
So Amanda's actually already mentioned that to me, and we agree that we think it'd be really useful to share that as a kind of opportunity. I think the best advocates would be some of the people who've attended. So we had a great gang actually from Norfolk and Waveney. They were fabulous. They all sat together at lunchtime at a great big long table and really enjoyed the time together. And they also enjoyed the opportunity to discuss some issues across sectors and so on as well. And equally from SNE. So maybe what we could do is maybe ask some of those participants if they wouldn't mind supporting maybe something at a staff briefing, something like that. That would be helpful.
Let's take that as an action, shall we? Great. Okay, thank you, Susanna. Any other questions or points? Otherwise, we'll move on. Thank you to the BAF. Amanda, all yours.
Thank you very much, Chair. Hopefully you can hear me better now. Right, okay. So here we have our September Board Assurance Framework, and it's actually, pleasing is not the right word, but a lot of the risks which are on our BAF have been already discussed, as we know throughout the morning so far. And what I wanted to highlight are 3 particular risks today, Chair. We have 2 new risks, which we have indeed previously discussed throughout the morning. The first is around our new launch of the financial ledger system, which is known as IFSE2. That's launching in October, and that has been a conversation and more that we've played out at audit committees, and it was through the audit committee that they rightly have escalated that risk to our BAF, and Chris may want to say a few more words afterwards. And the second risk, which we have previously already discussed, is around the new electronic patient record, EPIC, which is going to be implemented at ESNEFT at the beginning of October. The entry that we have in front of us has been written by our Strategic Digital Investment Committee, but has actually had the endorsement of ESNEFT at the same time. That risk has been ongoing, and there's been a lot of work across the system for probably over a year now, and primary care have been absolutely front and centre to the conversation and debate to ensure that all things patient safety are worked through in readiness of launch and beyond. So lots of activity ongoing there. And the third risk that I wanted to obviously remind us of is a live risk, and that's risk number 34, our running cost reduction. And I think it's fair to say it's live and has daily attention from multitudes of people as we manage that risk going forward. And I think the way I would describe that risk is in two halves. One focusing on the workforce and the people aspect, and the second is around our governance, current and future governance. We have lots of governance which oversees how we manage that risk, notably through the board, but also through our transition committee for Norfolk and Suffolk, and many of us are on that committee. And also we play that through our remuneration committees, of course, as well. So lots of governance woven through that. It remains a significant risk, notwithstanding the financial aspect and the reference to redundancy and the like going forward, which we still await further information. But I think the best thing that we are doing to manage that risk at the moment is making sure that our workforce is supported as best as possible. We committed to a number of work streams pertaining to our staff in March. That continues, and as far as I'm concerned, we cannot overdo how much support we provide our staff. It's really unprecedented. The future is uncertain, but I think in terms of our approach and the approach that we're taking to our workforce and wider stakeholders, we're managing that risk to the best of our advantage and opportunity. And on that point as well, I just wanted to highlight that last week we had a change day for our staff at Endeavour, which was supported by nearly 100 staff with outside agencies. So that's another example of how we are continuing to manage and drive that risk from a workforce perspective. I will pause there, Chair, but I'm sure my fellow directors may want to identify or highlight any of their current risks. Thank you.
Thank you, Amanda. Chris, did you want to add anything as Audit Chair?
Yeah, I mean, thank you, Amanda. The finance system is posing a bit of risk, and the audit committee did feel that it has to come in the overall risk framework, mainly because I don't think we have a test environment. We are going directly live situation. So it has its own inherent risk with that. So it is important that it is made aware at the board level, and that's why we recommended that it should be in the board assurance framework.
Okay, thank you, Chris. Howard?
Yeah, just to say, Amanda, that risk 25, apologies, it needs updating, so I'll action that through Finance Workforce Performance Committee, because yeah, I think it looks like that was last updated in February, so yeah, that needs to be sorted out. We'll get that corrected for November.
Thank you, Howard. Kath?
Thank you. Regarding risk 8, which is the adult mental health risk, I wonder if there's an opportunity to update some of that as well. I think one of the risks is predicated on a number of our services being requires improvement. Community mental health services is now rated good, which we're delighted at, all recognising there's still more to do. I think some of the controls that are in place can be reflected on the BAF more helpfully for you, so we can work with you on that. And some of the mitigations, I think, particularly ADHD, and albeit small, you know, there's a really positive recovery college programme for people who are waiting on the ADHD waiting list that is commissioned by Richard's team, that's having great outcomes, and we have a patient story coming to our board in public at the beginning of October on that particular service. So I think there's some ways in which we can strengthen that. Thank you.
Thank you, Kath. And I saw Amanda nodding, so we'll take that as a future action. And Lisa?
Thank you. I was just going to say that we had a deep dive. I hope I'm not stealing your thunder. We had a deep dive on Strategic Risk 3 at Quality Committee last week, I think it was. So you'll note on that risk, this is around waiting lists not meeting constitutional target of 18 weeks. The impacts arising from that risks are, the second one is increased patient safety risks, including harm due to long waits. And our Healthwatch Suffolk colleagues came and presented the wealth of information they had from their deep dive into understanding people's experience while they are waiting on our elective waiting lists, and presented that, and we were really appreciative of kind of getting that narrative from people around how it impacts on their lives, their pain, employment, family lives. When we talked about how we understand patient safety risks, particularly with our acute providers, I think we recognised the need that we need to do some more work to understand that. So I think there is not enough understanding of how people experience harm while they're on those waits. So that was an action from Quality Committee that we're going to look at that. Thank you.
Okay, I think we look forward to that update. Yeah, and again, Amanda, you will have captured that, won't you? Thank you. And Dave?
Thank you, Chair. Just an update on the GP collective action. I know General Practice Committee voted formally last week to go into a formal dispute with the government over the contract changes, of which industrial action is a possibility.
Okay. Thank you, colleagues. So we've got a number of updates that will come through to November board. As of today, are we happy to note that those works in progress are happening and to approve the paper as presented today, subject to that work? Happy to do that? Agreed. Thank you very much. Item 18, committee minutes and highlights. There are 3, Finance Performance Workforce, North East Essex Alliance and the West Suffolk Alliance. Are we happy to take them as read and go straight for questions?
Yeah. Just to note that there is a Quality Committee one which was published subsequent to the...
Oh, yes, thank you, and I hadn't scribbled that down. Thank you, Tom, plus the Quality Committee one. Thank you. Any questions for either non-executive member, chair, or indeed exec? Otherwise, we're asked to receive and note. All done, thank you. Item 19, the attendance log is to note, unless there are any questions. Noted. Any other business? None has been raised, but I'm with me prior, but I'm just looking around the table, so wave at me if you have any other business. None raised, in which case then let's go to item 21, which is questions from the public. And Simon, I'm going to start with you. You've got some questions already logged, and then we'll go to members of the public in the audience. I'll ask you to introduce yourself and ask your question if you've got one. So Simon, all yours.
Okay, we've got a few questions here from Anthony Dooley. His first question is as follows. Could the board provide an update on this issue, which relates to the employment of PAs and AAs, in the context of the knowledge that 3,000 GPs will be newly qualified soon, yet there are only 60 GP posts available in the UK? Are GPs not the bedrock of the NHS, and following Leng, isn't it the case that all patients should initially be seen by a GP?
Frankie.
Thank you, Simon, and thank you for the question. The board strongly feels that general practice is indeed the bedrock of the NHS. However, general practice is not just GPs. The general practice team also includes pharmacists, paramedics, practice nurses, advanced nurse practitioners, many other people make up those teams now. And so with such a wealth of different skills, it's no longer the case that every patient will always be seen by a GP in the first instance, and it is no longer appropriate. I would rather see a physio for my knee than a GP, I'm afraid. However, the Leng Review is a call to arms. The Leng Review makes multiple recommendations, 18 in total, including one which is to change the name of physician associates and anaesthetic associates to physician assistants. Another provides welcome clarity on the scope of patients that physician associates should be seeing, and in particular stipulating that they should not see undifferentiated patients. So patients need to have been reviewed or vetted by the doctor to say who is the most appropriate person to meet that individual's needs. There is another recommendation that PAs will spend 2 years in secondary care before they can move into general practice. So a huge amount of work. The government has fully endorsed those recommendations, and so as a system we are now undertaking a stock take to ensure that we are ready to meet them in due course.
Thank you, Frankie. Back to you, Simon.
Okay, the second question from Anthony Dooley is as follows. The minutes record that Ed Garrett stated that he did not feel it was the role of the ICB to comment upon conflict in the Middle East. Now that the UN has declared Israel's actions in Gaza as a genocide, will Ed ensure that from now onwards, he will use the correct term to describe the reality in Gaza, i.e. it's a genocide?
Thank you. Ed?
Thank you for the question. I think, as I said last time, the conflict in the Middle East isn't part of the business of this board, so it's not appropriate from me or any other colleague to issue a comment.
Thank you. Simon?
Okay, the third question from Anthony Dooley is as follows. Further, his statement was inaccurate. Indeed, Caroline Donovan, showing intelligent and sensitive leadership, did email all NSFT staff following Amina's representation, thereby demonstrating that Ed didn't speak for the board. Would Ed withdraw his statement, and would Nick Hughes like to show similar intelligence and sensitivity towards staff at ESNEFT following Caroline's lead? One of his staff has a brother imprisoned for nearly a year as one of the Fulton 18, for example.
Thank you. Ed?
Same comment and sentiment as before. Yeah.
Okay, thank you. Simon?
Okay, the next question from Anthony Dooley. Finally, will the board make a statement and publicise it widely regarding Palantir that has not only provided surveillance details in the genocide in Gaza, but has been given a government contract, in brackets, yes, another example of privatisation that Ed chooses to deny, close brackets, to have access to everyone's health data without most people's knowledge, and certainly not with their consent?
Thank you. Ed?
Same issue, no relevant comment available.
Okay, thank you. Simon?
The following then are questions from Andy Benson, and I'll quickly read those out. If the answers to the following questions are not reported in the open agenda for the 23rd of September ICB meeting, please provide the following information, and they are as follows. The questions: within the SNE area, please provide a list of the planned redundancies that were announced at a previous ICB meeting. The second question is: how many FTE posts have to date been subject to redundancy in respect of clinical services, administrative and management services, and what is the total to date of redundancy payments due to the staff affected? The next question is: who is to meet those redundancy costs? And the final question is: please indicate the areas of reduced clinical activity service that have been affected by this redundancy programme and the impact on patients as a result.
Thanks, Simon. Ed, you may wish to answer. I don't know whether, Amanda, if you've got anything to add, you can come in, but I'll go to Ed first.
Yeah, the transition process is ongoing. We're not in a position to answer those questions factually yet. Once we've concluded the process, we'd be very happy to do so. Of course, we're working to ensure that there's no adverse impact to services, and we had a discussion around risk just earlier, so it's very much in the board's eye line.
Anything to add, Amanda?
Nothing to add, Chair. Thank you.
Okay, thank you. Any more, Simon? Okay, and questions from colleagues in the audience? Any? We've got one. Have you got the microphone? Thanks, Simon. If I'll leave it to you to introduce yourself, Jim.
Hello, I haven't seen some of you at all ever, and quite a few of you for many years. My name is Michael Nimi. I'm a district councillor at East Suffolk District Council. I've been involved and following health delivery in particularly Suffolk Coastal since 2003, which is a sentence nobody really should be having to serve. So I made it here today through the wonderful countryside and followed sat-nav and the traffic lights, and eventually got here, I think, 2 minutes before you kicked off, so didn't really have a chance to talk to those that I know. But I think I would just like to make a comment to Ed, who made, I believe, a congratulatory statement with regards to Essex University, but failed to mention that Suffolk University has made significant strides, and in the Times University list of this Sunday have moved up the ladder, I think, by 20-odd positions, has been commended in a number of areas, and perhaps we should celebrate Suffolk University as well as Essex University. Particularly, I believe Suffolk is doing some introduction of dental work, and we're desperately in need of that. You're aware, I believe, in fact it was stated earlier, that local government is undergoing a massive reorganisation, the biggest in 50 years, and you'll be unsurprised to see that the different levels of councils don't have a unified view of what should be happening. And you are also probably aware that tomorrow the councils will make their representation to Westminster, and oddly they will be actually suggesting that the new unitary authority becomes either one council or three, missing out the obvious one in the middle, two. There must be a good reason for that, but I, as a district councillor, wait to see that. And all of us will have an opportunity to be consulted by Westminster following their deliberation over what's been stated. Now, you yourselves are going to disappear, so join the club. You've been in existence for a long time. I think you've had a very difficult task. I, for a short time, was the Community Health Cabinet member, and I had to cover both your ICB and Norfolk and Waveney ICB, and the differences were notable. The sizes of the committee were big, and quite honestly, how you're going to end up with a Norfolk and Suffolk ICB, the size of the group around the table will be huge. And how you're going to communicate with the patients that you're serving is something that I think requires an awful lot more thought and work that seems to have been given to it. I would like to move on to a question.
Yes, please. I was just about to prompt you, Mike.
I know you were. Okay. Last week at an overview and scrutiny meeting, the leader and the chief executive of East Suffolk District Council stated that a long-time aspiration of the GLI administration of our district council was that we became a Marmot place. And it would appear that that is going to happen, and we're hoping that Professor Marmot will be coming to Suffolk in October, and we will get that on. And following on from that, last night I was at the Felixstowe District Sports Council meeting, and we were being given a briefing by an organisation called Suffolk Active, who will be sort of the agent for Sports England in endeavouring to encourage folks that are playing sports to continue to play, younger people to engage and start playing sports, but equally important, older folk to be able to play sports. So both, I think it was football, cricket and rugby are endeavouring to generate walking football, walking in all those sports. The parish council has been doing a lot of work with increasing and improving play space. But the key thing that came out of the debate was that the only free sport activity that exists is walking. Everything else, you need equipment, you need to be able to pay the club fees, etc., etc. So I'm really asking you in your dying days, and you have got a lot of time, it would appear, that is it possible that social prescribing by our GPs could be probably better funded and they could actually encourage or be able to subscribe a greater period of sport activity for folk? And I've got a vested interest. My wife had a heart attack 2 years ago. She had triple heart bypass. She had 6 weeks of provided exercise, but it was recommended she continues, but she pays for that and is able to pay for that. There are a lot of people who are finding it very difficult to find that money, and particularly going back to Professor Marmot, he was saying the actual difficulty of very low-income folk to actually have a good diet, exercise, water flows, the whole bit is a difficulty. We need to close that gap. So can we support our GPs to give a longer-term social prescribing, and how could it be done?
Great question, Mike. Thank you. Maddie.
Thank you. And yes, we're all very excited about the Marmot Place. I was really pleased to be invited to be part of that board and have accepted that invitation. Thank you to the council. So I think this is exactly the area that's so important in our collaboration. It's what our local area partnerships with the voluntary sector, community organisations and with East Suffolk Council is all about. So I will take the very specifics away and discuss with your officers and with Louise and colleagues about what more we might be able to do through social prescribers and the other partnerships that we have. So I take that as an action, Chair. Thank you.
Okay, thank you, Maddie. Okay, colleagues, we are 3 minutes past 12, so apologies we're 3 minutes late, but I think we are going to close and look forward to our next meeting on the 25th of November. So meeting closed. See you all on the 25th of November. Thank you, everybody. Thank you.